फेल इस कारण से हुआ था क्योंकि उसको जॉइंडिस हो गया था। अचानक से 8 जून को डॉक्टर ने उसको एडमिट किया। एडमिट करने के बाद उसको 1-2 दिन में उसका लीवर फूलता गया, उसके पेट में पानी आता गया धीरे धीरे। फिर उसकी सोनोग्राफी जल्दी 1-2 बार करवाई गई। उसको डॉक्टर ने रेफ़र कर दिया, बोला इसको लीवर सिरोसिस हो गया। फिर हम लोग वहाँ पे सब यहाँ वहाँ से पता किए फेसबुक पर। फिर हम लोगों ने फेसबुक में बेंगलोर के एस्टर आरवी हॉस्पिटल देखा, वहाँ पर डॉक्टर राजीव लोचन का पूरा फेसबुक में वीडियो सुना। वीडियो सुनने के बाद हम लोगों ने वहाँ पे डॉक्टर राजीव लोचन और वहाँ पे जो कोऑर्डिनेटर हैं डेल्सन, उन लोगों से सबसे बात की। डॉक्टर ने कहा इसको लीवर ट्रांसप्लांट करना पड़ेगा। फिर वहाँ पे अग्रवाल फाउंडेशन है और मिलाप, इन लोगों ने मिलकर हम लोगों की बहुत सहायता की, जिससे पूरा पैसा इकट्ठा हुआ। 15 लाख के समथिंग पूरा पैसा इकट्ठा हुआ। उसके बाद एडमिट करने के बाद मेरा और मेरी बेटी का ऑपरेशन किया गया।
डॅमेजचा त्रास होता, आम्हाला माहिती नव्हतं त्याचा लिव्हर डॅमेज झाले. ते ग्लोबल हॉस्पिटलच्या ज्या उषा मॅडम होत्या आणि राजेश डॉक्टर या लोकांनी आम्हाला प्रवीण फाउंडेशनचा पत्ता दिला आणि तिथून आम्हाला जी मदत मिळाली त्याच्यामुळे आज माझ्या मुलाचं ऑपरेशन होऊ शकलं. प्रवीण सरांचे खूप आभार मानू इच्छिते की आज त्यांच्यामुळे आज आमचा मुलगा आमच्या खूप सर तुमचे धन्यवाद.
ತುಂಬ ತೊಂದರೆ ಇತ್ತು. ಲಿವರ್ ಜಾಂಡಿಸ್ ಆಗ್ಬಿಟ್ಟಿದ್ದು ಮಗುವಿಗೆ. ರಾತ್ರೆಲ್ಲ ನಿದ್ದೆ ಮಾಡ್ತಿರಲಿಲ್ಲ ಮಗು. 5 ವರ್ಷದಿಂದವ ಮೈ ಈಚಿಂಗ್ ಆಗೋದು, ಮೈ ಕೆರ್ಕೊಳ್ಳೋದು, ಮತ್ತು ನಮಗೆಲ್ಲ ತುಂಬ ತೊಂದರೆ ಆಗೋದು. ಮನೆಯಲ್ಲಿ ಮಲಗ್ತಿರಲಿಲ್ಲ ಮಗು 5 ವರ್ಷದಿಂದವ. ಇದಕ್ಕಿಂತ ಮುಂಚೆ ಒಂದು ಇಂದಿರಾಗಾಂಧಿಲಿ ಆಪ್ರೇಷನ್ ಮಾಡಿಸಿದ್ರೆ ಅವ್ರು ಸಕ್ಸಸ್ ಆಗಲಿಲ್ಲ. ಈಗ ಅಷ್ಟೇ 4 ತಿಂಗಳ ಹಿಂದೆ ಆಶ್ರಸಿಮೆ ಹಾಸ್ಪಿಟಲ್ ನಾವು ಆಪ್ರೇಷನ್ ಮಾಡಿಸಿದ್ವಿ ಲಿವರ್ ಟ್ರಾನ್ಸ್ಫರ್. ಅಂದರೆ ಇವ್ರಿಗೆ ಲಿವರ್ ಕೊಟ್ಟಿರೋದು ಇವ್ರ ತಾಯಿನೇ ಲಿವರ್ ಟ್ರಾನ್ಸ್ಫರ್ ಮಾಡಿಸಿದ್ವಿ. ಫೈನಾನ್ಸಲ್ಲಿ ತುಂಬ ತೊಂದರೆ ಆಯಿತು ನಿಮಗೆ ಮಾಸಕ್ಕಿಂತ ಮುಂಚೆ. ಆಶ್ರಸಿಮೆ ಹಾಸ್ಪಿಟಲ್ ಮೇಡಮ್ ಈ ಥರ ಹಿಂಗೆ ಹೆಲ್ಪ್ ಮಾಡ್ತೀನಿ ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ಪ್ರವೀಣ್ ಅಗರ್ವಾಲ್ ಫೌಂಡೇಶನ್ ಮತ್ತು ಮಿಲಾ ಫೌಂಡೇಶನವರು ನಮಗೆ ತುಂಬ ಹೆಲ್ಪ್ ಮಾಡಿದ್ರು, ಸಪೋರ್ಟ್ ಮಾಡಿದ್ರು.
इनको लिवर ट्रांसप्लांट करना करके, इसके लिए 18 लाख चाहिए था. प्रवीण अग्रवाल फाउंडेशन से मेरे को सहायता किया है, उनके लिए बहुत धन्यवाद करता हूँ.
मेरी बेटी का लीवर फेल इस कारण से हुआ था क्योंकि उसको जॉइंडिस हो गया था। अचानक से 8 जून को डॉक्टर ने उसको एडमिट किया। एडमिट करने के बाद उसको 1-2 दिन में उसका लीवर फूलता गया, उसके पेट में पानी आता गया धीरे धीरे। फिर उसकी सोनोग्राफी जल्दी 1-2 बार करवाई गई। उसको डॉक्टर ने रेफ़र कर दिया, बोला इसको लीवर सिरोसिस हो गया। फिर हम लोग वहाँ पे सब यहाँ वहाँ से पता किए फेसबुक पर। फिर हम लोगों ने फेसबुक में बेंगलोर के एस्टर आरवी हॉस्पिटल देखा, वहाँ पर डॉक्टर राजीव लोचन का पूरा फेसबुक में वीडियो सुना। वीडियो सुनने के बाद हम लोगों ने वहाँ पे डॉक्टर राजीव लोचन और वहाँ पे जो कोऑर्डिनेटर हैं डेल्सन, उन लोगों से सबसे बात की। डॉक्टर ने कहा इसको लीवर ट्रांसप्लांट करना पड़ेगा। फिर वहाँ पे अग्रवाल फाउंडेशन है और मिलाप, इन लोगों ने मिलकर हम लोगों की बहुत सहायता की, जिससे पूरा पैसा इकट्ठा हुआ। 15 लाख के समथिंग पूरा पैसा इकट्ठा हुआ। उसके बाद एडमिट करने के बाद मेरा और मेरी बेटी का ऑपरेशन किया गया।
माझ्या मुलाला लिव्हर डॅमेजचा त्रास होता. आम्हाला माहिती नव्हतं त्याचा लिव्हर डॅमेज झाले. ते ग्लोबल हॉस्पिटलच्या ज्या उषा मॅम होत्या आणि राजेश डॉक्टर ह्या लोकांनी आम्हाला प्रवीण फाउंडेशनचा पत्ता दिला आणि तिथून आम्हाला जी मदत मिळाली त्याच्यामुळे आज माझ्या मुलाचं ऑपरेशन होऊ शकलं. प्रवीण सरांचे खूप आभार मानू इच्छिते की आज त्यांच्यामुळे आज आमचा मुलगा आमच्या खूप खूप सर तुमचे धन्यवाद.
ನನ್ನ ಮಗಳಿಗೆ 7 ತಿಂಗಳು ಮೈನಿಂದ ತುಂಬ ತೊಂದರೆ ಇತ್ತು. ಲಿವರ್ ಜಾಂಡಿಸ್ ಆಗ್ಬಿಟ್ಟಿದ್ದು ಮಗುವಿಗೆ. ರಾತ್ರೆಲ್ಲ ನಿದ್ದೆ ಮಾಡ್ತಿರಲಿಲ್ಲ ಮಗು. 5 ವರ್ಷದಿಂದವ ಮೈ ಈಚಿಂಗ್ ಆಗೋದು, ಯಾವಾಗ ಮೈ ಕೆರ್ಕೊಳ್ಳೋದು, ಮತ್ತು ನಮಗೆಲ್ಲ ತುಂಬ ತೊಂದರೆ ಆಗೋದು. ಮನೆಯಲ್ಲಿ ಮಲಗ್ತಿರಲಿಲ್ಲ ಮಗು 5 ವರ್ಷದಿಂದವ. ಇದಕ್ಕಿಂತ ಮುಂಚೆ ಒಂದು ಇಂದಿರಾಗಾಂಧಿ ಆಪ್ರೇಷನ್ ಮಾಡಿಸಿದ್ರೆ ಅವ್ರು ಸಕ್ಸಸ್ ಆಗಲಿಲ್ಲ. ಈಗ ಅಷ್ಟೇ 4 ತಿಂಗಳ ಹಿಂದೆ ಆಶ್ರಸಿಮೆ ಹಾಸ್ಪಿಟಲ್ ನಾವು ಆಪ್ರೇಷನ್ ಮಾಡಿಸಿದ್ವಿ ಲಿವರ್ ಟ್ರಾನ್ಸ್ಫರ್. ಅಂದರೆ ಇವ್ರಿಗೆ ಲಿವರ್ ಕೊಟ್ಟಿರೋದು ಇವ್ರ ತಾಯಿನೇ ಲಿವರ್ ಟ್ರಾನ್ಸ್ಫರ್ ಮಾಡಿಸಿದ್ವಿ. ಫೈನಾನ್ಸಲ್ಲಿ ತುಂಬ ತೊಂದರೆ ಆಯಿತು ನಿಮಗೆ ಇದು ಮಾಡಿಸೋಕ್ಕಿಂತ ಮುಂಚೆ. ಆಶ್ರಸಿಮೆ ಹಾಸ್ಪಿಟಲ್ ಮೇಡಮ್ ಈ ಥರ ಹಿಂಗೆ ಹೆಲ್ಪ್ ಮಾಡ್ತೀನಿ ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ಪ್ರವೀಣ್ ಅಗರ್ವಾಲ್ ಫೌಂಡೇಶನ್ ಮತ್ತು ಮಿಲಾ ಫೌಂಡೇಶನವರು ನಮಗೆ ತುಂಬ ಹೆಲ್ಪ್ ಮಾಡಿದ್ರು, ಸಪೋರ್ಟ್ ಮಾಡಿದ್ರು.
इनको लिवर ट्रांसप्लांट करना करके इसके लिए 18 लाख चाहिए था. प्रवीण अग्रवाल फाउंडेशन से मेरे को सहायता किया है, उनके लिए बहुत धन्यवाद करता हूँ.
मेरी बेटी का लीवर फेल इस कारण से हुआ था क्योंकि उसको जॉइंडिस हो गया था. अचानक से 8 जून को डॉक्टर ने उसको एडमिट किया. एडमिट करने के बाद उसको 1-2 दिन में उसका लीवर फूलता गया, उसके पेट में पानी आता गया धीरे धीरे. फिर उसकी सोनोग्राफी जल्दी 1-2 बार करवाई गई. उसको डॉक्टर ने रेफ़र कर दिया, बोला इसको लीवर सिरोसिस हो गया. फिर हम लोग वहाँ पे सब यहाँ वहाँ से पता किए फेसबुक पर. फिर हम लोगों ने फेसबुक में बेंगलोर के एस्टर आरवी हॉस्पिटल देखा, वहाँ पर डॉक्टर राजीव लोचन का पूरा फेसबुक में वीडियो सुना. वीडियो सुनने के बाद हम लोगों ने वहाँ पे डॉक्टर राजीव लोचन और वहाँ पे जो कोऑर्डिनेटर हैं डेल्सन, उन लोगों से सबसे बात की. डॉक्टर ने कहा इसको लीवर ट्रांसप्लांट करना पड़ेगा. फिर वहाँ पे अग्रवाल फाउंडेशन है और मिलाप, इन लोगों ने मिलकर हम लोगों की बहुत सहायता की, जिससे पूरा पैसा इकट्ठा हुआ. 15 लाख के समथिंग पूरा पैसा इकट्ठा हुआ. उसके बाद एडमिट करने के बाद मेरा और मेरी बेटी का ऑपरेशन किया गया.
त्रास होता. आम्हाला माहिती नव्हतं त्याचा लिव्हर डॅमेज झाले. ते ग्लोबल हॉस्पिटलच्या ज्या उषा मॅम होत्या आणि राजेश डॉक्टर ह्या लोकांनी आम्हाला प्रवीण फाउंडेशनचा पत्ता दिला आणि तिथून आम्हाला जी मदत मिळाली त्याच्यामुळे आज माझ्या मुलाचं ऑपरेशन होऊ शकलं. प्रवीण सरांचे खूप आभार मानू इच्छिते की आज त्यांच्यामुळे आज आमचा मुलगा आमच्या खूप खूप सर तुमचे धन्यवाद.
पंद्रह दिन पहले मालूम पड़ा इनको लिवर ट्रांसप्लांट करना करके. इसके लिए 18 लाख चाहिए था. प्रवीण अग्रवाल फाउंडेशन से मेरे को सहायता किया है, उनके लिए बहुत धन्यवाद करता हूँ.
मेरी बेटी का लीवर फेल इस कारण से हुआ था क्योंकि उसको जॉन्डिस हो गया था. अचानक से 8 जून को डॉक्टर ने उसको एडमिट किया. एडमिट करने के बाद उसको 1-2 दिन में उसका लीवर फूलता गया, उसके पेट में पानी आता गया धीरे धीरे. फिर उसकी सोनोग्राफी जल्दी 1-2 बार करवाई गई. उसको डॉक्टर ने रेफ़र कर दिया, बोला इसको लीवर सिरोसिस हो गया. फिर हम लोग वहाँ पे सब यहाँ वहाँ से पता किए फेसबुक पर. फिर हम लोगों ने फेसबुक में बेंगलोर के एस्टर आरवी हॉस्पिटल देखा. वहाँ पर डॉक्टर राजीव लोचन का पूरा फेसबुक में वीडियो सुना. वीडियो सुनने के बाद हम लोगों ने वहाँ पे डॉक्टर राजीव लोचन और वहाँ पे जो कोऑर्डिनेटर हैं डेल्सन, उन लोगों से सबसे बात की. डॉक्टर ने कहा इसको लीवर ट्रांसप्लांट करना पड़ेगा. फिर वहाँ पे अग्रवाल फाउंडेशन है और मिलाप, इन लोगों ने मिलकर हम लोगों की बहुत सहायता की, जिससे पूरा पैसा इकट्ठा हुआ. 15 लाख के समथिंग पूरा पैसा इकट्ठा हुआ. उसके बाद एडमिट करने के बाद मेरा और मेरी बेटी का ऑपरेशन किया गया.
त्रास होता. आम्हाला माहिती नव्हतं त्याचा लिव्हर डॅमेज झाले. ते ग्लोबल हॉस्पिटलच्या ज्या उषा मॅम होत्या आणि राजेश डॉक्टर ह्या लोकांनी आम्हाला प्रवीण फाउंडेशनचा पत्ता दिला आणि तिथून आम्हाला जी मदत मिळाली त्याच्यामुळे आज माझ्या मुलाचं ऑपरेशन होऊ शकलं. प्रवीण सरांचे खूप आभार मानू इच्छिते की आज त्यांच्यामुळे आज आमचा मुलगा आमच्या खूप खूप सर तुमचे धन्यवाद.
ತುಂಬ ತೊಂದರೆ ಇತ್ತು. ಲಿವರ್ ಜಾಂಡಿಸ್ ಆಗ್ಬಿಟ್ಟಿದ್ದು ಮಗುವಿಗೆ. ರಾತ್ರೆಲ್ಲ ನಿದ್ದೆ ಮಾಡ್ತಿರಲಿಲ್ಲ ಮಗು. 5 ವರ್ಷದಿಂದವ ಮೈ ಈಚಿಂಗ್ ಆಗೋದು, ಯಾವಾಗ ಮೈ ಕೆರ್ಕೊಳ್ಳೋದು, ಮತ್ತು ನಮಗೆಲ್ಲ ತುಂಬ ತೊಂದರೆ ಆಗೋದು. ಮನೆಯಲ್ಲಿ ಮಲಗ್ತಿರಲಿಲ್ಲ ಮಗು 5 ವರ್ಷದಿಂದವ. ಇದಕ್ಕಿಂತ ಮುಂಚೆ ಒಂದು ಇಂದಿರಾಗಾಂಧಿ ಆಪ್ರೇಷನ್ ಮಾಡಿಸಿದ್ರೆ ಅವ್ರು ಸಕ್ಸಸ್ ಆಗಲಿಲ್ಲ. ಈಗ ಅಷ್ಟೇ 4 ತಿಂಗಳ ಹಿಂದೆ ಆಶ್ರಸಿಮೆ ಹಾಸ್ಪಿಟಲ್ ನಾವು ಆಪ್ರೇಷನ್ ಮಾಡಿಸಿದ್ವಿ ಲಿವರ್ ಟ್ರಾನ್ಸ್ಫರ್ಟು. ಅಂದರೆ ಇವ್ರಿಗೆ ಲಿವರ್ ಕೊಟ್ಟಿರೋದು ಇವ್ರ ತಾಯಿನೇ ಲಿವರ್ ಟ್ರಾನ್ಸ್ಫರ್ ಮಾಡಿಸಿದ್ವಿ. ಫೈನಾನ್ಸಲ್ಲಿ ತುಂಬ ತೊಂದರೆ ಆಯಿತು ನಿಮಗೆ ಇದು ಮಾಡಿಸೋದಕ್ಕಿಂತ ಮುಂಚೆ. ಆಶ್ರಸಿಮೆ ಹಾಸ್ಪಿಟಲ್ ಮೇಡಮ್ ಈ ಥರ ಹಿಂಗೆ ಹೆಲ್ಪ್ ಮಾಡ್ತೀನಿ ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ಪ್ರವೀಣ್ ಅಗರ್ವಾಲ್ ಫೌಂಡೇಶನ್ ಮತ್ತು ಮಿಲಾ ಫೌಂಡೇಶನವರು ನಮಗೆ ತುಂಬ ಹೆಲ್ಪ್ ಮಾಡಿದ್ರು, ಸಪೋರ್ಟ್ ಮಾಡಿದ್ರು.
Good afternoon, everyone. It gives me immense pleasure to welcome you all for our webinar ALTC 2020, that's Affordable Liver Transplants Conclave 2020, organized by the Pravin Agarwal Foundation, a philanthropic organization dedicated in making liver transplants in India affordable, accessible, and available for every child in need. Since its inception in 2016, the foundation has supported nearly 200 kids get a liver transplant done and lead a healthy life thereafter. Every year, we hold a round table to bring in together the best minds in pediatric liver care and prevention to share their insights, discuss the challenges and outcomes of pediatric liver transplant to make it more affordable and accessible for all. The theme for this year is pediatric liver transplants and COVID-19. As we all know that the recent pandemic has thrown our lives off track. Nevertheless, it couldn't dampen the indomitable human spirit. We found unconventional ways to move ahead and stay connected, a reason why ALTC 2020 is streamed as a webinar connecting all of us virtually today. I would also like to tell you all that Pravin Agarwal Foundation now goes digital with a new app. Now, I would like to request Mr. Pravin Agarwal, the founder of the Pravin Agarwal Foundation, Chairman Sterlite Power Transmission Limited, and Vice Chairman Sterlite Technologies Limited to share a few words with us and inaugurate our new app. Over to you, sir.
Thank you, Debjani. And good afternoon, ladies and gentlemen. A very warm welcome, good afternoon to each one of you. It gives me immense pleasure to welcome you all to the third edition of Affordable Liver Transplants Conclave 2020, organized by Pravin Agarwal Foundation. These are challenging times, and all of us have been affected by the COVID-19 epidemic, one way or other way. Given the pandemic and its restrictions, we have organized this year's conclave as a webinar. Technology and health delivery systems have never been more relevant than it is today. The theme of this year's conclave is geared towards pediatric liver transplants and COVID-19. We started this initiative with the support of Dr. Sonal Asthana in 2016 by supporting 13 children in need of a liver transplant. And I'm happy to inform you that we have now enabled nearly 200 children get a liver transplant done and lead a healthy life thereafter. I would like to share a small story, friends, of 2.5-year-old Swara, who was suffering from a rare metabolic liver disease, progressing kidney failure, and a hint of a liver cancer. And she underwent a liver transplant at Sahyadri Hospital, Pune. In November 2019, like any other father, Swara's father was also very determined that his daughter should survive. Sahyadri Hospital, Pune, one of our partner hospitals, TPAF together with other fundraising partners, generate the funds for her to undergo a liver transplant. Post-transplant, also her medical journey was troublesome. However, she was in best of hands of Dr. Bipin Vibhute and Dr. Sheetal Mahajani at her care. Today, she's leading a healthy life, and nothing gives me more satisfaction than seeing the kid and her parents happy and joyous. Today, it is great to see each and such an extensive gathering of experts and knowledge leaders joining with us virtually, taking their time out to share their opinions and perspectives with us and extend their support to our cause. I'm pleased to inform you that we have received more than 500 registrations for this webinar today. In today's digital world, friends, where everything is just a click away, the foundation is proud to launch TPAF app for easy access to patient and hospitals to file in support requests. With all this new app, we promise an efficient and prompt services to the patients. The app is also intended to create a knowledge forum where people can ask questions regarding liver health to experts. We promise to continue with our efforts to make affordable liver transplant a reality. We also welcome suggestions and plans for a better outreach. I extend my heartfelt gratitude to all the doctors, healthcare professionals, our panelists, moderators, speakers, and our wonderful audience who came together despite the current global distress to support our cause from across the globe. I'm very confident that moving ahead, the discussions are going to be indispensable in making liver transplants accessible and affordable in the times of COVID-19. We promise to continue with our efforts to make affordable liver transplant a reality. We also welcome suggestions and plans for better outreach. I extend my heartfelt gratitude to all the doctors, healthcare professionals, our panelists, moderators, speakers, and our wonderful audience again to come together despite the current global distress to support our cause from across the globe. I'm very confident that moving ahead, the discussions are going to be indispensable in making liver transplants accessible and affordable in times to COVID-19. Thank you.
Thank you so much, sir, for your words. And I'm sure that with the all new app, it would be making patients' experience more hassle-free, more easy and quick. And as sir said, that it would also be a knowledge sharing platform where patients can ask doctors about liver health, liver care tips, and get even prevention tips. Now, moving ahead, we would like to start our webinar on pediatric liver transplant and COVID-19. So I would request Dr. Sanjay Rao, Senior Consultant and Department Head of Pediatric Surgery, Solid Organ Transplant Program, Narayan Health Hospital, Bangalore, to take over the talk and initiate our first panel discussion. I would also like to tell our viewers and eminent panelists that since we are pressed for time, we would try our best to stick to the timelines given to us and wrap up this discussion on time. A time ticker would be appearing on your screen to help you wrap up this talk within the given time slot. And I would also tell our viewers that you can ask our panelists questions by typing them in the comment sections for YouTube, and Zoom attendees can do the same in the chat box. Over to you, Dr. Rao.
Good afternoon, ladies and gentlemen, and good day to others who are not in the afternoon time frame. I think Rohit Kohli is sitting in the middle of the night, and I'm sure it is more in the evening in Philippines. So welcome to this webinar. I think at the outset, I need to thank Mr. Pravin Agarwal and the Pravin Agarwal Foundation team for their continued support to pediatric liver transplantation, and also the annual conclaves that they hold. And definitely these conclaves have grown in stature, in content, and participation over the years. So thank you very much. This afternoon, we are the opening batch people for the first panel discussion. And I have a very, very august and a very learned panel with me. And we are going to start the discussion by talking about how COVID-19 has affected liver transplantation, pediatric liver transplantation within our country. So joining me in the discussion are very eminent panelists. The first is Dr. Arvinder Soin, who is the Chairman and Chief Surgeon at Medanta Liver Transplant Institute. He is a Padma Shri recipient for pioneering liver transplantation in India and is also the founder president of the Liver Transplant Society of India. Welcome, Dr. Soin. The next is Dr. Mohammad Rela, who is the chairman and managing director of the Rela Institute and Medical Center in Chennai. He is a very, very eminent hepatobiliary surgeon and transplant surgeon, and is also the president-elect of the International Liver Transplant Society. Welcome, Dr. Rela. Dr. Darius Mirza is also a very eminent transplant and hepatobiliary surgeon. He is based at the Apollo Hospitals in Navi Mumbai and is also professor of HPB and transplant surgery at the University Hospital, Birmingham. He is the founder of the G Transplants Group. I also welcome Dr. Catherine Tay, who is the president of the Philippine Association of the Hepatobiliary Surgeons. She is the director of the PCS Cancer Commission. She is the co-director of the Liver Center and the National Kidney Transplant Institute. She is the chief section of hepatobiliary surgeons at the Makati Medical Center. She is also a minimally invasive surgeon, a surgical oncologist at the Department of Surgery, St. Luke's Medical Center. She is the president and founder of Love Liver Foundation and is based in the Philippines. And our last panelist, the very well-known and popular Dr. Sonal Asthana, who is the clinical lead and hepatobiliary multi-organ transplant surgeon based at the Aster Integrated Liver Care Center Group. Welcome to all the panelists. I will get the ball rolling by asking questions one by one, and I would request each one of you to please give in your ideas and thoughts. The first question is, what are the guidelines that are currently being practiced in managing pediatric liver transplant patients during this epidemic? As time has passed, I'm sure understanding has improved, but what are the current guidelines that you are all following in your respective hospitals with respect to the recipient, the live donor, and the cadaveric donor? I think we would start in the order that I introduced. So, Dr. Soin.
Thank you, Sanjay. Now, managing liver transplantation in the donor and the recipient is actually no different from the non-COVID times. But the COVID times have necessitated certain protocols that have to be followed to make sure that the donor and recipient are free of COVID before and after, and the healthcare workers are protected. So that's the basic theme of what has changed with COVID. I mean, we've done, I think, Neelam, 11 or 12 transplants in the last 4 months, and they've all done well. So we've actually not stopped our program at all. Now, the protocols we specifically follow for COVID times, we make sure that the recipient, the donor, and the attendant are actually quarantined for, initially the protocol was 2 weeks, and now we basically quarantine them for 1 week. So they can't just go out anywhere except, if they have to come to hospital, we would admit the patient, and the mother would typically stay with the patient, right? But otherwise, they have to be quarantined in their place for 7 days at least before the transplant. They have to have 2 tests negative for COVID RT-PCR, the donor, the recipient, and the attendants, both the attendants. So that's essential. All the healthcare workers are tested in our hospital every 5 to 7 days, or when there is an exposure and indication. Then we basically have clear divisions, and we have a very large campus, so we have clear divisions of COVID and non-COVID corridors. We have our East Wing, which is basically non-COVID, and our West Wing, which is COVID, and the entrance, exit, and the staff managing each are totally separate. So separating COVID, non-COVID, testing them out before the surgery, and then during surgery, of course, everybody in the OR, whether it's a housekeeping person or a nurse or a OT technician, both on the anesthesia and the surgery side, and of course the surgeons and the anesthetists, everyone has full surgical kits, not PPE kits. Not those white overall things which you see, but regular surgical kits with a visor. So there is a full visor, which is used only once. We don't have that helmet type thing, which is used case after case. So those are certain precautions that we've actually been following with COVID. We've had 5 patients, pediatric patients, who've had COVID during these times. 3 non-transplant patients who have chronic liver disease, and 2 post-transplant, but they are long-term post-transplant. We've not had any donors or recipients have COVID early post-transplant. So the long-term ones were 2 and 3 years out, and they did well because they were mildly symptomatic, one, and the other one was asymptomatic, and we really didn't do anything. We didn't give any antivirals or anything. And Dr. Neelam is here. She could actually spell out what she did for the chronic liver disease patients who hadn't had transplants. Neelam, you want to just chip in quickly?
Yeah, there was one patient, 3 years old, who had not only a liver disease, but she had the multi-system involvement, which is quite classically known in children, which is resembling like Kawasaki, where we say multi-system involvement. There we did have to use IVIG infusion along with steroid. That was the only patient. And the other patient was an AHPVO who surprisingly had a chylomicrosis, and we treated the COVID and that, but we did not give any steroids or antiviral in the other two patients. And the post-transplant patients, as Dr. Avi said, they were more than 2.5 years, but both of them were less than 4 years old, both of them. And only the supportive management was done. And there was no increase in liver enzymes during this course. They continued with the same immunosuppression that we were giving.
Dr. Rela, would you like to comment on what the practice is in your institution?
Okay, I think Dr. Soin has said quite a lot of what we would do, and there has been some recommendation. I think the time scale has slowly changed how we practice over a period of time. I think when in March, the end of March, I think everything really shut down. The whole of India shut down, really. People were scared of going out. It is strange that the number of cases now are much more than then, and everybody is very relaxed about it. I think everybody is now somewhat relaxed about it. We have to say the patients are relaxed about it and the doctors are relaxed about it. So in really April, we restarted the liver transplant program because we were losing patients. I'm both talking about adults and pediatrics. There isn't a huge difference in terms of how we prepare them, except the attender for pediatrics is very important, I guess. So what happened to us? We did 5 cases and everything went smoothly. We were doing 2 tests, and in the beginning, many people were asking, what is the purpose of 2 tests? I think for the background, we also need to understand the publication which came out from Birmingham University. I think that is quite a scary publication. I don't know, maybe Darius can talk about it a bit later. About mortality of perioperative mortality of patients acquiring COVID, irrespective of what the operation is. That was almost 19, I think. It was 19% or 21% was the mortality. If any patient, even a cholecystectomy or appendicectomy, if they acquired COVID perioperatively, the mortality of these patients were extremely high. That is a scare. That is extremely scary. That means we can never dream of doing a living donor operation, because if the donor got COVID perioperatively, then there is a 20% risk of mortality. There is no way anybody would want to do the operation. But I think that data may be for very early COVID period. I don't think that data is applicable today. I think currently they are actually, as we speak, for the month of October, they're doing an international trial for perioperative mortality of COVID. Birmingham is now doing. We are also one of the centers. I think they've got hundreds of centers that they've pulled in to give data on perioperative mortality for COVID positive. So with that as a scare, we started. And believe it or not, and the 5th patient, we were doing 2 tests, 5 days before the operation, 1 day before the operation. The reason obviously is one test, there is a 30% false negativity, and therefore you need to do 2 tests. And we also felt if you did just 1 test before the operation, if the patient actually comes into contact with a person 3 days before the operation, the test the day before the operation will obviously be negative, and they would get positive maybe second post-operative day. So we also have a hotel attached to our hospital. So we isolate them for a week, do the test 5 days before and 1 day before. And if both tests are negative, then we subject, that is the patient, relative, and the donor recipient and the relative, all of them have to be negative. And if any of them are positive, then the operation is postponed by 3 weeks. So we are actually offering the operation 3 weeks after they're negative. They are asymptomatic, really. Most of them are asymptomatic. So the 5th case, the donor became positive, and this was early times, and the government was really coming down on us in a big way. And we also had 2 patients with chronic liver disease who became positive. and both of them died because they had decompensated liver disease. So we shut down. We shut down for nearly 3 weeks, and we did nothing really, no transplants. And then we started because we thought that the perioperative mortality is not as high as it seemed anyway. By May, we started, and we've been following this protocol. We have done closely 20 pediatric liver transplant in this period, in the 6 months period of COVID. We've done, I think, around 20 pediatric liver transplant. We have not had any perioperative infection, not one patient pediatric, and totally we may have done another 30 or 35 adults. We have not had any perioperative infection. But we did have one recipient at the time of discharge had a cough. It was COVID negative 300, but the chest CT was somewhat classical for COVID. So we have to assume that patient had an infection just before discharge, but it was completely asymptomatic. So this has been our experience. We've been very careful. We have also a designated COVID hospital. At any time, we have around 120 COVID patients admitted to a hospital. It's split into two anyway. The hospital is split into two. So our doctors manage, they go through a rotation process. So even the liver surgeons, the hepatologists all have to do COVID duty. And when they finish their COVID duty, they stay off work for a week and then come back to their routine.
Thank you, Dr. Rela. Dr. Mirza, would you like to comment on what your practice has been here, and also, what data is coming out of Birmingham?
So I think in Birmingham we were right at the beginning of the pandemic. There was some data that had come out from Italy, which was largely just one-off communications with colleagues in northern Italy. So there was really no information available in early March at all. The hospital, once the pandemic was declared, the hospital was under huge pressure to upscale ICU resources. This is the adult hospital. So they had to increase the ICU bed facility from 100 beds to 450 beds. And at its peak, we had about 200 ICU beds occupied by COVID patients and about 400 to 500 regular ward beds occupied by COVID patients. So we saw a very similar, very high early peak that London had seen 2 weeks earlier, and Italy had seen about 5 or 6 weeks earlier. In that early period, there was no COVID testing available at all. At that point, there was quite a bit of mortality in HEPL cases. And I think we contributed to an international survey where we contributed 4 or 5 patients, I think. So there was one post-cholecystectomy, a couple of post-Whipples. And on the basis of that, there was a decision made to slow down elective adult work and only keep the adult fulminant program going. So transplanted a few fulminants. There was big pressure to stop children. Now we deliver children's at a completely separate facility. And some of us had to fight quite hard to keep the pediatric program going because there were donors becoming available. Some of the adult centers had closed on for elective work. So we managed to divert some of the cadaveric organs from the adult pool to the pediatric pool. So the bigger kids tended to benefit from that difficult early period. We've also seen 2 or 3 other good things that have happened. So we restarted adult work about 2 weeks after stopping, and within a 6 to 8 week period, we were straight away there at the activity that was there before, between 20 and 25 transplants a month. The pediatric activity actually did increase over that early period because grafts, I think, were diverted. But there were 3 or 4 practices that evolved that were fantastic. So one was to prioritize patients nationally on the adult front. So we put together a national pool of recipients that were high-end recipients, so fulminants, and this high-end group, which is approximately 100 patients across the whole country. And we did the same thing on the pediatric side, and we prioritized children between the 3 centers so that if livers were to become available, these sicker kids would benefit. So the prioritization helped the adult patient prioritization, helped the centers focus on the higher risk patients. It prevented lower risk patients undergoing transplantation in the early period of uncertainty. And then eventually there was also at the same time a reduction in organ donation, because obviously the whole national ICU bed capacity was taken up by provision for COVID. And this took 3 months to evolve. And by the time we got to early June, The donor pool was beginning to get back to where it was. The recipient pool started to get back to where it was. And by the end of June, we opened up all the routine elective waiting lists to exactly the same allocation system that was there pre-COVID. We're still continuing with some practices. The current focus now is on second wave planning and execution of second wave. So centers budding up, what to do if one center closes down? Is there a buddy center that can take things on? What to do in the setting where the ICU capacity is not available? What do you do for a short-term stoppage? What do you do for a longer-term stoppage? So all those are the current areas of focus. So it's a situation that's kept on changing. Has it made a big impact to patients receiving transplants? Not really. I think we've contributed 5 or 6 patients to another international study on COVID in post liver transplantation. There's one death in a retransplant about 6 to 8 weeks post cadaveric transplantation that was COVID positive. And the other 4 are a mix of either asymptomatic disease or mild disease in patients who are quite late after transplantation. In the children, no real impact at all, both in terms of positivity and also in terms of having abnormal tests making life difficult. I'm interested to hear what people are doing in the living related situation where one family member or both donor and recipient land up being positive. Just to finish off the question about the India side of things, I think the guys are doing exactly what Avi and Mohammed have explained. There are obviously concerns, but I think that initial fear, thankfully, is not there, and I'm happy to move on.
Yeah, I think so. Let's look at. We will come back to how we manage if either the donor or the recipient gets positive, before the procedure and how long to wait, etc. Can we get Dr. Catherine on board, please, about how the situation is and how we all have managed pediatric transplants in Philippines during this time?
Good afternoon, everyone. Thank you very much for the invitation to participate here, especially to the Pravin Agarwal Foundation. There's a lot has been said by Professor Soin and Professor Rela and Mirza. In the Philippines, unfortunately, we don't really have much activity in terms of the liver transplant landscape. Just before the lockdown in March, there was one living donor liver transplantation done for a pediatric patient. That was just fortunate that it happened at that time. It was done in the medical city, and the patient developed fever post-operatively, but luckily tested COVID negative. So all the protocols that were mentioned earlier are the same, and we are just a little bit more strict in terms of the COVID testing or the swabbing, which is repeated or should be done within a week prior to any contemplated procedure. And it should be repeated if the patients will test positive. And making sure that the parents of children will also receive vaccination for pneumonia. So these are some of the things that we can apply. So thankfully, during this time, because of the fear of patients coming to the hospital, since our numbers are still currently very high, it hasn't really come down as much as other countries have experienced. So the transplant activity has not really resumed. So no transplantation has been done since the lockdown until today. And during this time, we were able to look into, it was a good time for us to look into guidelines, look into how we can prepare to resume and to prepare our patients and screen our patients. So all the guidelines that were mentioned earlier are similarly part of our guidelines as well. One of the things that we think is difficulty is the blood, because of the lack of blood for possible transfusion during surgery. we tend to add that into the equation, seeking for blood donors in case any transplantation or any surgery is to be done for the patients. There's a lot of social media campaign to increase the information and the awareness of patients in terms of hospital safety, patient safety, and healthcare worker safety as well, trying to bring them back into the hospital because parents fear bringing their children, even just for consultation alone. This is something that we need to address, and that in itself is a roadblock, such that patients become more ill and we see them, we lose them along the way. So I think there's really nothing much that I can add. Oh, the other thing also is contact tracing. In our operative procedure, part of the checklist is a contact tracing form already, so that if after any surgery, including liver transplantation, any person within the team develops any signs or symptoms of COVID, anyone in the team would be already called, the attention will be called and tested. So that's one of the things also that can be adapted for the rest of the transplant.
Thank you, Dr. Catherine. Dr. Sonal Asthana, would you pitch in about how you all are managing in your centers with the ongoing COVID crisis here? I mean, Kerala and Karnataka both have been sort of hitting new spikes over the recent weeks.
I think that much has already been covered. It's probably well to remember that we've probably lived through several iterations of different spikes and guidelines over the last 6 months. So to start back to what we did in March and April when there was a complete lockdown, I think the Liver Transplant Society of India moved early and decisively, which was great. Because if you recall, at that time, all COVID patients had to go to government hospitals and there weren't enough testing kits to go around. So the LTSI came out with guidelines of testing donors and recipients quite early. And Dr. Soin and Professor Gupta were instrumental in getting it into the ICMR guidelines for testing as well. So as a transplant community, we never had a problem testing people, before we, so I think that that was sort of the effort of good organized work together. Regarding who to be transplanting, initially there was a lot of confusion about elective versus urgent. There were several stable biliary atresia patients who potentially could wait, and there were people with tumors and ACLF type situations who could not. And we transplanted about half a dozen people in the first 2.5 months or so who were supported following those guidelines. We've been fortunate not to have any COVID in our patients. So far, so I couldn't tell you. I think Dr. Soin and Professor Illa would be better placed to answer those questions.
Okay. Thanks, Sonal. I think that the next question is, if a patient has come to you for a transplantation and preoperatively either the donor or the recipient turns out to be COVID positive, what are your guidelines? How long do you wait? Do you repeat tests? What has been the practice? Because this is a problem we are facing increasingly, at least in Bangalore. Dr. Soin, again, we will start with.
So we've had that situation arise a few times in adults, not in children, where the patient or donor being evaluated for transplant have tested positive. The donors, we've not actually accepted any of these donors for transplant, although all of them have done okay. I mean, there were 3 of them who did not have the surgery and they did okay, but they were not donors anymore after that. Recipients, we've had close to, I think about 15 or 16 patients who are being evaluated for surgery who turned positive. We've lost 7 of them. So that just goes on to say that the mortality of COVID with chronic liver disease is very high. That is what Secure Cirrhosis and all the other registries of the world that have gotten together, the COVID HEP and AASLD and APASL, there are these registries that we are part of for COVID. everybody found the same thing, that there is 20 to 30% mortality in chronic liver disease patients, especially those who are decompensated. In fact, that is the reason why I'm telling all my follow-up patients, when I say I means our team, telling all our follow-up patients to not sit at home with decompensated chronic liver disease that needs a transplant. They should just go ahead and have a transplant. They're much safer with a new liver than with their chronic liver disease in case they get COVID. So that's what's happened. Now, there are 4 patients who were COVID positive and then subsequently turned negative, whom we've transplanted, who've done well. So that's that. We've had 20 odd patients post-transplant turn COVID positive. 6 have been early and 14 have been late. We've lost 1 late patient who had chronic rejection. So again, the patient we lost had, in a sense, he had chronic liver disease because he had chronic rejection, high bilirubin, etc. He was waiting for a retransplant. So he died with COVID long-term, 6 years post. And the other 13 did okay post-transplant who were long-term out. Among the 6 who had it short-term after transplant, early after transplant, within the index admission, really, 4 have done well, fine. 2 of them are in ICU. 1 is pretty critical at this point in time. We've had 1 donor had early post-transplant COVID on day 10 after discharge. She's doing okay.
Dr. Rela, what has been?
Sorry, just to say that we published 2 papers on this. One in liver transplantation and one in JCEH. They're both available online.
Thank you, Dr. Soin. Dr. Rela, what has been your practice about if one of your donor or recipient is positive before surgery?
Yeah, before surgery, I think we have had quite a few donors who have tested positive. When the first incidents came, that was in late March or early April, I can't remember. I felt that we didn't know much about this disease, and therefore, like Abby said, I couldn't consider that as a donor. So we did the transplant with another donor. But subsequently, we have had quite a few donors who have tested positive, and now we wait for 3 weeks and then give them a date for the operation. And they've done okay. We have not had any problem.
Do you repeat tests?
Do we repeat tests? No. Maybe we have done, but the point is there is no point in repeating the tests. Even if they are positive after 3 weeks. Now, I think things have moved on to such an extent that we even move patients out of ICU who tested positive 2 weeks later to the non-COVID area, because the belief is that they are not infective really. After 3 weeks, even if they are positive, they are not infective. And they have antibodies anyway. So the simple answer is I don't want to say that maybe we are testing them. I don't know. I'll find out. But even if they are tested positive, I don't think it's a reliable test after 3 weeks. So it doesn't mean anything whether they are positive or negative. So instead of waiting, as Abby said, I think decompensated chronic liver disease patients waiting for a transplant is a much more dangerous situation than them acquiring COVID after the transplant. I think we now know that patients acquiring COVID post-transplant, in the post-transplant period, actually don't do that badly. I think the Italian study says only 3% mortality in them. So the danger is for them to have chronic liver disease. And we have had many patients with decompensated chronic liver disease who have died. We are also contributing. And the first 2 cases we reported is actually published now in Hepatology International as an acute on chronic. So my 3 weeks is my time, really. There are patients pushing for 2 weeks. We have resisted that. But we don't know if the recipients are very sick, you wouldn't know what to do with that. But now 3 weeks is happening. For the recipients, I said, we have not had any donor test positive for post-op. We have not had any recipient test positive so far, other than 1 patient we felt had COVID, but was still PCR negative. But we have had maybe 4 patients long-term. One was a high-profile patient in the early 20 years after transplant. The transplant was actually done in Birmingham. Darius might know him. He's a member of Legislative Assembly in Chennai who's been doing well. Very obese and with renal impairment. His pre-op creatinine was actually, his creatinine, he died. So that was one of the early high-profile deaths in Chennai. But subsequently, we have had, I think, 2 deaths. The long-term post-transplant patients, but they were not actually admitted with us. We knew that they were admitted in other centers in other towns. And so that's our experience of long-term post-transplant COVID. Short-term post-transplant COVID, we haven't.
Dr. Mirza, would you like, what has been your practice if either the donor or the recipient or a cadaver is positive? How is it looked at?
We now have access to the rapid test for the last couple of months, and that has definitely shortened the turnaround time. But we've had situations where a donor has been positive. Obviously, the cadaveric donation process is stopped completely. We've also had a situation where a recipient has tested positive. Obviously, we had the opportunity to go for another recipient. We've not done any living-related transplantation in Birmingham since the COVID situation, but the team are doing some in India. And again, there is this dilemma of how long to wait. And I think what the guidance that we just had from Mohammed and from Avi is helpful in terms of what would be the requirements to be able to proceed with a relatively safe transplant, given that COVID with end-stage disease has got probably the worst prognosis possible.
The point also is that the 3 weeks wait, they have to be asymptomatic. You can't wait for 3 weeks in somebody who's actually had a pneumonia. So the chest CTs have to be normal if you want to consider them as a donor or recipient.
Yes.
Otherwise, the wait may have to be longer. You can't have a 3-week rule and say it's been 3 weeks from onset of symptoms, we're going to go ahead. Their chest CTs have to be absolutely normal.
So do you routinely do a chest CT before you you accept them?
No, if they are completely asymptomatic, it's not an issue, really. If they have had an illness, fever, cough, and they've been admitted to hospital, most of our donors are completely asymptomatic. It's an incidental finding that you test them and then you find them positive. I mean, nobody's had symptoms. But if they've had symptoms, you may have to be very cautious about them.
Okay, I think we have 5 more minutes to go. I will just pose a question looking forward into the future. That what long-term effects would COVID have, in liver transplantation, specifically pediatric liver transplantation here, in terms of protocols, practices, costs, and other issues that may come up going forward? Is it going to change our practice forever and ever going forwards? Dr. Soin?
I think COVID is going to change our life, has already changed our lives, and is going to change our lives for the foreseeable future, maybe a year or two. I don't want to gaze too far into the crystal ball. I think life will be normal as we knew it, maybe a couple of years from now. I don't think, like I said before, I don't think the practice of liver transplantation, or for that matter, pediatric liver transplantation, has changed greatly, except for the repeated testing and understanding COVID disease. And I completely agree with Mohammed that it's been shown that you may secrete or excrete the coronavirus for up to 90 days, because that's how long the respiratory epithelium takes to shed and renew. And those shedding virus particles may actually mean nothing. They may not mean active infective virus. So after 3 to 4 weeks of recovery, it's okay to assume that someone's negative. So that's one thing. But yes, we are going to continue to have to take precautions for donors and recipients, especially donors, and make sure we do not harm a donor in ignoring the testing routine and so on. And I would also do a chest CT on every donor or patient that has had COVID and now is being accepted for a transplant. We would do a pre-transplant chest CT.
Dr. Raila, how do you see the future?
Can I ask people, does the Birmingham data still hold good? Does Darius believe that the Birmingham data of the perioperative mortality of COVID is still right? I think the second study in October probably will give us an answer, because it is too scary to think that the perioperative mortality is so high in patients when they acquire COVID just before or after the operation.
I think, Mohammed, what I would say on that is that the mortality of COVID in general has come down. And therefore, I believe that post-operative mortality of COVID also would be down. But of course, the data remains to be seen. That's what my feeling is.
But the point I want to say is, see, if you look at India, the mortality we say is 2%, and many may not agree with the Indian statistics. But even if you double it, it's less than 5% anyway, it's 4%. And most of them are really in the elderly group, whereas the perioperative patients are not necessarily in the elderly group. It is composed of all age groups, which is worrying, because the younger patients in our country don't really require active treatment. Actually, we are not treating majority of the patients with antivirals or anything. So I agree that the mortalities come down. The mortalities come down probably we better understand the introduction of steroids and the anticoagulants, and also to some extent the antivirals has come down. But it's only come down in the elderly group. I don't think the younger patients' mortality changed that much. I think it has always been good, which is why I think we need to. Probably they'll come up with answers after the second study of why it has been so high in the first study.
I would just like to inform all our panelists and the moderator that we are running short of time. The time ticker had already started. I think you guys missed it. So, I mean, we have to wrap up. So any questions, if we, any more questions, Dr. Rao, you have to ask them, the panelists,
Yeah,
and let's wrap up in next few minutes.
Yeah, I think what I will do, I mean, there are no questions from the audience as I can see it here. So I shall just give a couple of minutes to the three other panelists to sort of give their thoughts, and then we will wind up quickly, a couple of minutes each. We'll start with Dr. Mirza, then Dr. Catherine, and then Sonal.
I have one.
Neelam, you're on mute.
Yeah,
I wanted to get one comment, especially related to this scenario. Let me know when I can.
Yeah, Dr. Mirza, would you like to comment a couple of lines of how it looks through the crystal ball going forward?
I don't think he's there.
Yeah, I think he's dropped out, I think.
He's dropped out.
We think we lost him due to some technical difficulties, or I think he has some prior meetings, so he had to drop from this conclave altogether.
So,
but
we'll
it
go
was
to Dr.
nice.
Catherine. How do you see the future going forward in your country as far as transplants and COVID is concerned? Do you think it's going to bring about major change?
Well, definitely it's going to bring about major change in terms of the algorithm that and the guidelines that we follow, because the testing of the COVID has come into the picture, plus a lot of other small things, precautions, and a lot of education and information campaign trying to change the fear factor. So there is a lot of change, I think, in our country to change the mindset mostly of patients, not only for pediatric but also for cirrhotic patients, and also add up to how we can help them tide over this period of delay in terms of treatment, especially for liver transplantation. So these are very important things that we will have to work on in our country, especially when the numbers are still not that low. And I think the discipline in terms of people to observe the basic principles of precaution for COVID-19 should be implemented at all times.
Thank you. Sonal, would you like to comment on how you see the future?
Well, I think the future is already happening, to be honest. I mean, we've had a rough 10 days. We've had to cancel 4 transplants, 3 adult and 1 pediatric, where 3 recipients turned out to be positive, 1 donor turned out to be positive. So the last 10 days, I think, is an indication of where we are heading. And I must remind you that we haven't really peaked in India yet, So I think it's a little early to say what's going to happen after COVID. We haven't really seen the worst of it yet. I suspect it's going to be worse right now. A quick word about the tests that we are talking about. The antigen test, which is the rapid test, has high specificity but a very low sensitivity. There are several people who would be antigen negative who would later turn out to be RT-PCR positive, and they are probably just as much at risk from a donor or a recipient mortality perspective. So PCR is probably the go-to test for a living donor situation. I mean, a cadaveric infusion is a different.
There is a PCR test which is also rapid. You can get an answer in 2 hours.
And the 1.5 hour test that's just come in this thing. So far the rapid tests in India that have been used are what are called the RAT tests, the rapid antigen tests, and those are probably not nearly as good as a PCR. The second aspect, I mean, just taking up what Dr. Rela said is, I mean, I don't think we can directly use the data that we have for mortality in younger people and extrapolate it to patients who are having an operation, particularly because the risk in a donor situation is disproportionate. So that's probably the biggest worry that comes to mind. I respect the fact that we have to do transplant, but we can't underplay the risk either. So I think that doing the PCRs in the way and a CT scan probably is the way forward, at least for the intermediate future. I mean,
well, I think
that the population risk probably doesn't necessarily translate well to a risk in the perioperative setting.
Yeah, but
right, I think I will.
About large surgery, Sonal. We're talking about all surgery. Anybody who has any surgery was at risk of 20% mortality. That's what is a little difficult to understand.
Well, that is true. Yeah.
That's what I'm talking about. I'm not talking about donor surgery. There is no data on donor surgery, but there is data on any surgery.
Yeah.
Yeah, I think we are sort of out of time, and I will wind up the panel here. I think it is encouraging that there is some uniformity in the way all of us are approaching the problem in different centers and different parts around the world. I think there is some sort of consensus about how to do these things. That the fact that we have to go forward and what is the safest way to go forward. And I'm sure as more information comes, these will be refined. And I'm very, very glad that there is so much of uniformity in thought about how these patients have to be managed. So I think we are just on time, and I will thank all the panelists for their participation, and I will hand you over back to the organizers for carrying this thing forward. Thank you very much to all of you.
Thank you, Sanjay. So I'd like to thank Mr. Pravin Agarwal, and he needs to be congratulated. He and his team need to be congratulated for all the passion and service for pediatric liver transplantation. And I just need to peel off now. Thank you all. Bye.
Thank you.
Thank you. Just one comment to be. I had just one comment, Sanjay.
Sure.
Sometimes when
please.
Talking about the donor.
Yes, Dr. Neelam, we can hear you.
Yeah, please go ahead, Dr. Mohan.
To say that, especially when we've been talking about the donor testing, I want to highlight that the donor can become even positive post-transplant. So I had a very interesting scenario where the mother was the donor and the baby was sick, so was in the ICU. And we shifted the child back to the ward. And when normally it is always that the mother wants to, go and be with the child. And as luck would have added, I just routinely out of the blue said that make it a habit to check the donors who are going to be sitting in the room with the child. Not necessarily the donors' attendants. And can you believe this mother who was positive, which was post-donation, and the child was negative. So I had learned it from an experience from the adult where the adult recipient became positive because some attendant came to visit the patient from Lucknow or whatever. So this is what I wanted to highlight, that while we're always talking about the pre-transplant donor and all that, don't forget to screen your attendant who is sitting in the ward next to the patient taking care of the baby.
Yeah, I think that's a very, very valid point. Thanks, Dr. Neelam. Thank you very much.
Thank you so much, Doctor. Thank you, Dr. Sanjay Rao, for moderating this panel for us. I would also like to thank Dr. Arvinder Soin, Dr. Mohammad Rela, Dr. Darius Mirza, Dr. Catherine Tay, and Dr. Sonal Asthana for such an insightful and in-depth talk on pediatric liver transplant amidst this current pandemic. We really appreciate the time and efforts that you all have put in for ALTC 2020. Now, moving ahead, I would like to invite Dr. Sonal Asthana to take this webinar forward and start the next round. Over to you, Dr. Asthana.
Thank you so much. And thanks again, Dr. Rao, for sticking to time. I know it's very difficult with a lot of opinionated transplant personnel to do that. Fantastic job. I hope we can continue that. It's my pleasure to invite Dr. Rohit Kohli to deliver the next talk. Dr. Kohli is the director of Division of Gastroenterology, Hepatology, and Nutrition at the Children's Hospital in Los Angeles. He's also a professor of pediatrics at the University of Southern California, and holds the vice chair of the Pediatric Special Interest Group at the American Association of Study for Liver Diseases. Dr. Rohit is passionate about liver transplantation and liver disease, both in India and the US, internationally actually. And his passion can be gauged by the fact that he is up at 2 a.m. in the morning his time to deliver a talk for us. So he's going to be talking to us about the future directions of liver transplantation with a particular view to how access to liver transplant can be increased in countries such as our own. This is more about increasing access than about technique, so that it's of interest to the entire wider audience. Over to you, Rohit.
Thank you so much, Sonal. It's very kind of you to invite me, and to the Pravin Agarwal Foundation for doing the yeoman's work that they have been doing for so many years now to improve access to pediatric liver transplantation in India. So it's a short time frame where I have to put together the future directions in pediatric liver transplantation. And my thought was, what better version of future for pediatric liver transplantation if there is no transplantation, and we can take care of pediatric liver disease without surgery. Following such eminent surgeons may be a little bit of a challenging statement to make, but I thought I'd be provocative this morning. These are just a few of my disclosures. Leave them on for 5 seconds. So the objectives, I broke it down into 3 parts. First, I think, Sonal, you set the stage very well. It's awareness, and within awareness, you want to maybe club in ability to be able to do pediatric liver transplantation. And then the assessment of the ground realities, and trying to understand when and whom should be a appropriate candidate in all scenarios, but especially within the Indian scenario, given the resource constraints that individuals face in general. And finally, accessibility to the ability and to the assessed patient, which probably is the underlying theme of why this foundation is in place to begin with. So let's focus on awareness first. So we are probably talking to a very educated group of people here who know what pediatric liver transplantation involves. But for the few people on the live webinar who haven't been exposed to the multitude and breadth of disorders that lead to the potential need for liver transplantation, this is just a 30,000-foot view, but you can see so many listed congenital and acquired conditions that are amenable to being treated by liver transplantation for children. If I were to break this down into a much more maybe palatable, bite-sized capsule, we would see that most of the diseases we talk about that get transplanted are depicted in this pie chart with blue color, which are the cholestatic or jaundice type diseases. And then another large cohort is metabolic liver diseases, where children are born with a defect in how they either process fat, protein, or carbohydrates. And then unfortunately, some children will have tumors which are depicted in green, so liver cancer, and of course, acute liver failure or ALF. And then there still appears to be a small subset where we never find out why their livers failed. So we call them a special name called cryptogenic, but essentially it means we don't know. So in terms of again, the awareness part, why are pediatric liver specialists needed? There are many of them that are on this webinar today, but if you go out into general practice, I think a syndrome, just to pick on one, Alagille syndrome, identified by Professor Alagille in Europe long time ago now, was this very typical facies that you could see in an individual of varied age and penetrance. But you can see the triangular shape of the face is very similar across all of these different people that you can see in this slide. So to be able to have a patient walk into your clinic and you just look at them and you recognize that this could be a certain disorder, that is what awareness is all about. Of course, once you dive deeper into this disorder, there's many specific inherent conditions that are part of this syndrome, so to speak, some of which are shown on this slide, but more as an example than anything else, where you can pick up cardiovascular, spinal or skin lesions that are very much pathognomonic of Alagille syndrome. What else should we be aware of? What we should be aware of is what is happening in the lay press. And a few years ago, now almost 3 years ago, the Washington Post highlighted a new condition which was afflicting young adults and leading to a need for liver transplantation, a growing need for liver transplantation, and that is fatty liver disease. And especially in the Indian context, we know that diabetes, for instance, is very prevalent in low body mass index individuals. Similarly, we now know that fatty liver disease is also prevalent in low body mass index individuals within the Asian subcontinent, South Asian subcontinent, and Asia in general. And this seems to be a growing problem. So being aware of rare conditions like Alagille syndromes and being aware of the subset of the population which may be slightly overweight or obese even, and being therefore more susceptible to fatty liver disease. I think these are the kinds of things that when I say awareness, I think about. Ability is, of course, highlighted by the various speakers on the panel just before me. Dr. Soin, Professor Rela, Dr. Asthana, Dr. Rao have amazingly put together a constellation of programs, Dr. Darius Mirza, across the nation in India, where we have the ability to do liver transplantation. And the timeline has been very similar across the world for a lot of people. So I'll just pick on our own program here at Children's Los Angeles, where we started doing transplants in '98. And to date, we're almost at 400 pediatric liver transplants, of which 130 are in the past have been living donor liver transplants. And this is just a annual subset. So we're doing close to 30 odd transplants a year. And in the COVID context, this year to date, we've done 17 already. So we haven't stopped. Children, of course, have not stopped being ill from liver conditions, chronic liver disease, end-stage liver disease, and therefore our work has not stopped either. And the best part is when you put the ability into context, it is what are the outcomes? And down here at the bottom, I highlight that today, and again, just highlighting our data because it is public data, but I would say that all strong liver transplant institutes today that perform pediatric transplants aim to have 95+% 3-year patient survival, if not 100% 3-year patient survival. And this is the outcome. All of us want to have this beautiful picture. This young lady had a liver transplant 20 years prior to this picture being taken, and this young boy just had a living donor liver transplantation. So it was kind of a nice, what you call, merging of 20 years worth of transplants for us. So that was awareness and ability, but what do I mean by assessment? So when you talk about all these long laundry lists of disorders, how do you go about screening for them? How do you go about picking them up in the community? We talked about, Alagilles as an example, but that is not the most common reason for liver transplantation in children. Dr. Asthana was mentioning earlier a child with biliary atresia. That is the most common reason for a pediatric liver transplantation across the globe. More than 50% of all liver transplants being done for children are typically for biliary atresia. So how do we pick it up? There has been a lot of work in the past decade where we can now focus on screening for biliary atresia in various ways. When you do screen appropriately, you can do a surgical procedure. Pediatric surgeons have been doing this now. Once Dr. Moria Kosai invented this procedure back in the 1950s, if you find appropriately timed the diagnosis of biliary atresia, especially if you can do it under 60 days of age, you have a high success rate, close to 70 or more than that %. However, if there is delay in the diagnosis of biliary atresia, if you do not pick it up on time and you try to do a Kasai procedure after 90 days of life, the success rate dramatically falls. It's a sheer cliff that it falls off of. So time is bile. You want to keep the bile flowing, and you have to identify these children appropriately if you want the Kasai to work and have good potential for the Kasai to work. So the American Academy of Pediatrics back in about 2015, Dr. Casper Wong, a part of our group at CHLA, led this group, put together a position statement. And what they said was that we could screen with two different mechanisms. One is conjugated bilirubin concentrations, and the other is a much more accessible option called stool cards. So I'll highlight both of them in the next two slides. So a stool card, and this was pioneered in Taiwan and has been duplicated in British Columbia and many other parts of the world, where you can use the basic color of your child's stool to understand whether or not there is a blockage in their biliary system, if bile is flowing or not. And the top three here, of course, are abnormal, and the bottom three are normal colored stools with pigment in them. And this has definitely a potential for public health in pediatric offices. If we can do this right, this is a strong methodology of biliary atresia screening and identifying children at the right time. Another mechanism is more laboratory-based, and here you see a publication from Sanjeev Harpavat, who is a pediatric hepatologist in Texas at the Baylor College of Medicine and in Houston. And you can see that the top left graph here shows direct bilirubin, and the bottom in B shows total bilirubin. We can see when you look at total bilirubin, there is no difference between controls and children with biliary atresia. However, when you check conjugated or direct bilirubin, there is a dramatic difference, a significant difference between the two cohorts. Therefore, using conjugated or direct bilirubin as a measure within 24 to 48 hours of life. So you can pick these children up before they leave the nursery. And that is the key part here, early identification. So using stool cards or using conjugated bilirubin definitely has a screening potential. But what about other disorders? I mean, of course, biliary atresia is not the only reason for liver transplantation, the need for liver transplantation in children. This is one of the rarer causes identified typically in the past by mass spectrometry, bile acid synthetic defects. And you can see that this is the starting with the cholesterol molecule, how the whole pathways for direct acidic and so forth bile acid production happens. But not everybody has access to this kind of detailed analysis. When you do, however, have the ability to screen metabolically, we do see that there are now therapies. As I said on the very first slide, the goal in the long term would be to not need transplantation. And this is one such breakthrough where a simple bile acid substitute or supplement rather, cholic acid, has been shown to reverse and save children from the need of liver transplantation. And you do not have that primary bile acid defect active anymore once you supplement with cholic acid. Another way to screen these days is genetic screening. We have many panels that have come out, some within reach, some hopefully in the short to medium term will become even more accessible to individuals, as the costs for running these genetic panels drop precipitously every year. One such example, I'm not postulating for anybody.
Could I ask you to wind up in the next couple of minutes?
Yes, I'm almost at the end of my talk. Thank you. So this one chip, for instance, can detect 60 defects. The problem, of course, becomes interpreting. And so you do need experts who can look at all these variants of unknown significance to understand if they really mean something in the context of your patient. So what we are trying to do next is, of course, biomarkers. And so we've talked about simple tests and moving on to metabolic and genetic. But we also have patients who've had transplant who we want to understand whether they have rejection or not. And we have typically depended on liver biopsies, but our partner surgeon here, Juliet Emamali, she has now reached out and trying to figure out we can do liquid biopsies, so to speak. And recently the ASLD awarded her a grant to look at immune cells in rejection and trying to profile them such that we do not have to do a particular liver biopsy anymore. So last couple of slides, accessibility, which goes to the crux of the matter here. And we heard from Dr. Neela Mohan and the Soin, and this paper talks about how even in acute liver failure in India, now we're doing a great job in terms of outcomes for liver transplantation. And kudos to the group out of Chennai as well. They wrote an editorial along with this paper talking about how the financial constraints, and they hit the nail on the head here, that financial constraints continue to be the single most important factor in India. So that's where crowdfunding comes in. That's where the Pravin Agarwal Foundation comes in. And I think they're doing great work, as it's highlighted today, where we are now partnering together to help all these children. So last, but kind of a summary slide, I think awareness and the ability to do transplant exists. So there's a check mark there. Assessment, the tools are being developed, so we're halfway there, I would say. And finally, accessibility, there's a lot of work to be done, but that's what we are doing today, and I hope we can keep building on this in the future. Thank you so much.
Thank you so much, Rohit. I must apologize because we've been a little unfair to you, giving you such a big topic and asking you to cover it in a short period of time. But you've done fantastic work as always. Thank you. I really appreciate your insights. Just a sort of a quick question to you regarding the stool color card test. I mean, what in a country like India, if we were to launch a pediatric liver screening program, I mean, what would be sort of your advice for us, I guess, in terms of detecting, liver disease early?
I think the challenges are going to be unique. The biggest concern, even in the US, with the stool card testing was downstream costs. Because of course, these are not 100% sensitive or specific tests. These are screening tests. And when you pick up something on screening, you end up then having to do secondary testing, invasive testing, and therefore monetary and physical consequences can be definitely increased. So we have to be careful. We have to involve, I think, the pediatricians and also the MBBS doctor fraternity to make sure they understand when and how these screening tools are appropriate to be used.
Sure. And there are two questions from the floor. There was one question regarding, I think, your NASH interests, which were discussed. What can parents in India do to prevent liver disease, given that we have a high carbohydrate diet pattern?
I think I'll leave you guys with one simple message for that, which after 20 years of doing this, I think I can distill it down, which is, if it is sweet and you can pour, kick it out the door. Do not bring in any sugar sweetened substances into your home so that your children have to drink them, whether it is concentrated juice or sodas or Pepsi or something like that. I think it is a knowledge base that we have gained that this sugar sweetened beverage for industry has really done us a disservice, especially as pediatricians. We need to completely avoid those.
Sure. I think the next question was regarding does the transplant affect the adult life of the patient? I suspect that there are many people here who could attest to the fact that it really increases the quality and quantity of life already. So
yeah, I'll give you one anecdote and stop right there. I know we've gone over time. And the anecdote is, there is a individual who had a liver transplant as a child. She was a fulminant autoimmune hepatitis presentation at the age of 13, 14. And today that individual has not only gone to medical school, got married, but done a residency in pediatrics and done a advanced training in liver transplant, and now is an attending as a liver transplant physician. So yes, you can have a full life, and she also has a child of her own.
Fantastic. That's an excellent takeaway message. Are there any questions from our panel? Not just our this thing, because I think we have just 1 minute left. Professor Rela, Dr. Neelam, anybody? Dr. Sanjay?
Not really, nothing. Rohit, well done.
Yeah, that was great. Rohit, I just want to say that you showed this 97% 3-year. Now, I assume that a majority of the time, I guess maybe in India, malnutrition is quite an important part, because in the best of centers, whether it is ours or Rela's, we've been talking about 93, 95, and you quoted 97. So is it that the cohort in this group was more than 1 year? Because, you were talking about an LA group, or, do you see equally that sick patient in this new institute where you are in? Because 97 was a very big number as compared to an average of American.
Yeah, so this is the data I shared is publicly available. If you go to SRTR.
No, I'm just asking, is the cohort got less infants, less smaller children? That's what I meant.
Sorry, I misunderstood your question. So we have a proportion, I would say, of about 35% would be under 2 years of age. So it is a significant proportion. I'm not sure what your proportions are for under 2 years of age.
Rohit, what is the retransplantation rate? Is Naresh? I think because
Hi,
whenever
Naresh.
this paper comes up with 100% survival and 98% survival, when we look into the retransplantation, because there is an access to retransplantation, the survival rates of Western centers are much higher. But when you look into the actual sort of graft survival, then probably it matches with whatever our Indian scenario is.
Yeah, I'm not going to compare center to center, but I can definitely say that our retransplantation rates are also very low. So our graft survival is probably in the high 80% range, close to 90%, and the patient survival is, as you saw, 97 to 100%, depending on which 3-year cohort you look at. But definitely there is retransplantation, but it is a low number.
We'll have to close there.
I would like to intervene and say that we have already exceeded the time, so you would have to wrap up this talk.
Back to you, Debjani. Thank you.
Yeah, thank you so much. Thank you, Dr. Kohli, for sharing your perspectives on future directions in PLTs and taking your time from your busy schedule and connecting with us at 2 in the morning. We highly appreciate it. And thank you, Dr. Sonal Asthana, for hosting this talk. And moving ahead, I would like to request Dr. Neelam Mohan to take over the talk to our next panel discussion. Dr. Mohan is the Director, Department of Pediatric Gastroenterology, Hepatology, and Liver Transplantation, Medanta Med City, Gurgaon. Before we start and I hand it over to Dr. Mohan, I would like to tell our viewers that you can ask our panelists questions, typing them in the comment section of YouTube or just typing them in your chat box in Zoom. And doctors who are attending our on Zoom can also raise their hand if they have any questions to ask to our panelists. We will definitely take care of it and get them answered by our panelists. Now over to you, Dr. Neelam Mohan. Yes, Dr. Mohan, over to you.
Intermittently, I'm getting lost for like few seconds. Are others also facing this issue, or is it only with me?
No, actually, we are fine, Dr. Neelam.
Oh, I see. Then I think I need to even get another connection strong. I'll see. Maybe too late. So at the outset, I would like to thank my dear friend Pravin for having taken this stupendous work of supporting children for transplant. That's more important than just supporting transplant, because I think those who get connected to children and love them and realize that they need to equally live, because a lot of times we face this issue where young parents sadly would think about having, other children, especially in India. Without this foundation, I wouldn't know what we would be doing, because they were able to get many other foundations and many other supporters to join them. And I'm all in awe for them. And if I look retrospectively in the last few years, I think we didn't walk. really marched forward and took really leaps and bounds from where we started. So hearty congratulations to the Pravin Agarwal Fund for getting us all together. And I have some lovely speakers with me, and it is my proud privilege to start introducing from Dr. Mathur. Dr. Mathur, I've had the privilege of spending a lot of time with him, mostly on holidays rather than at work. And he's an amazing person to be holidaying with too, because his clinical skills, all his students talk a lot about it, because he's been one of the pioneers, I guess, surgeons in India who has been a GI and hepatobiliary surgeon and started with transplants, etc. He's right now the president of the Zonal Transplantation Coordination Center in Mumbai and is an emeritus professor in Department of GS Seth Medical College, KM Hospital, and in Mumbai. And my second panelist is Dr. Bipin Vibhute. Bipin, are you there? I can't see Bipin. Is he around?
Yes, I am around.
Okay, so can you put on your video, Bipin?
Yes, 1 second.
So Bipin is the program director for organ transplants, Sayadri Hospitals, Pune, Nasik, and Karad. Welcome, Bipin. And as you can see, Bipin is really fond of gymming and maintaining his body besides transplantation. Am I right, Bipin? Right. So Anurag, yes, Anurag, I can admire. Anurag Shrimal, he's the lead consultant. What is very unique is besides the liver transplant, he's also popular for his pancreatic transplant work, and he's a surgeon at the Global Hospital, Mumbai. And last but not the least, we have darling Sunaina Arora Singh with us, who is the CEO of Organ, which is the organ receiving and giving awareness network. And it's thanks to these people that we a lot to really work and support us, giving the organs, donations, and supporting it in all this work. Thank you, my dear panelists, for that. And I wouldn't waste much time because as the clock goes tick-tock, Debachni will start marching in. So, you know, I'll give you a scenario. Maybe I guess it was 2.5 weeks back. I get a call for a patient who had to be transported to me from Jaipur. The patient was in liver failure with INR 3.4, was in hepatic encephalopathy, grade 2, and they had to transport. So this is the call I get, and the enzymes were in thousands, and the diagnosis of acute liver failure was made there and being transported. So Bipin, with this scenario where you know you're going to be coming forward and seeing this child was 12 years old, so how would you now start about planning for, you know, first you will get the patient and you will decide whether you need or not transplant. So how do you approach this child? That's what I would say.
Yes, ma'am. Thank you very much. So in Maharashtra or in Pune specifically, these kids are seen by already pediatricians, and here pediatric hepatologists are very rare breed to see, and that is the fact. So unfortunately, we as a surgeon, we have to see these kids very often, and once we see, we have to get history, their clinical parameters, their previous investigations, and as we are talking about the financial constraint, we have to keep in mind, and we have to limit our investigations all the time. So if they are reliable investigations, if we get reliable history, and if we think these kids or patients, or specifically this type of patients, if they need transplant, then we have to move accordingly, because all of us know these kids, they don't give us much time.
Okay,
and
so now this child turned out to be he also had the viral serology outside was negative and his COVID test came positive. COVID RT-PCR came positive. So we have to now understand, is it the COVID? There are two scenarios. Is it COVID is just like sitting there and his liver is failed because of something, or is it the COVID which has failed? So that is number one step that we need to look at. Am I right, Bipin? So I
Yeah,
think the pathologist will help you out with it. So there were two scenarios. Fortunately for me, this patient had COVID positive, but also turned out to have dengue positive. I can't really believe that. And also had hepatitis B positive. So we started wondering how to go about it. And there was classical HLH. So we decided to go in for steroids. And we were lucky that this child could get saved because on ventilator. But imagine this scenario that my patient was lucky who responded to steroids, but was COVID positive, dengue positive, HLH, and managing this patient was a real nightmare. Suppose this patient turned out to be a hepatitis A liver failure with a COVID RT-PCR positive. How would you approach this patient? What are the challenges as a surgeon now? I, as a hepatologist, want you to go in for surgery. So what will be your challenges? Anurag, can you take now?
I mean, difficult case scenario, I would say, but I would like to, in terms of his COVID, I would as well like to get the antibodies, the COVID IgG and IgM antibody as well, to kind of understand the timeline where we stand in terms of his COVID infection, whether it is he has already developed the antibodies or not. Now, as far as an acute liver failure patient who has not responded to a medical management goes, I think we don't have definitive guidelines to take them through surgery. But in Maharashtra, there is this regulation. I mean, sir is there, Dr. Mathur sir is there. He can comment on that about the Director Health Services guidelines, and wherein the COVID positive patients, we will not be able to take them through transplant.
Dr. Mathur, can you comment on it?
Yeah, so this is what you're talking about, the recipient being COVID positive.
Correct.
And if you are taking elective transplant.
It is not elective. The patient is.
That's what I'm saying. That's what I'm saying. The regulation is for elective surgeries. In a permanent liver failure, which is a life-threatening thing, I don't think this regulation will come in the way.
Correct. So this is a very important message that you need to prioritize. The message is that COVID can just be a red herring in that patient. The patient has liver failure, has hepatitis A and maybe INR 6, and the patient needs a liver transplant. So the message is, in children, COVID is not so serious and patients have rarely succumbed to COVID with liver failure, because as we all know, it is ACE, more, the liver doesn't have that much of that receptors. It is more involving the lung and the gut. So several biopsies and several. So I think, as Dr. Mathur has highlighted, we should go ahead to save this child in this scenario over the. So as a surgeon, what precautions will you take? Bipin, what do you want to take for yourself precautions?
Yeah, in our center, we have developed two teams actually for the surgery as well as to take care post-transplant. And we have a separate green zone which carries the separate lift. And in the theater also, we before transplant, first team gets all the COVID tests done for each transplant. So far,
but this patient is positive. So you're going for a positive patient. You're a surgeon. Now I'm asking you to transplant a child who's positive. So
yeah.
What will you, how to protect yourself?
That is just a standard precautions, whatever precautions, COVID precautions we take, that's what we need. Unfortunately, we have transplanted one patient, unknowingly he was COVID positive and all tests were negative, but post-transplant turned out to be positive. So from that case, we learn a lot of things, how to tackle these COVID cases, COVID positive recipients, but we have no guts yet to transplant a recipient who is already positive and waiting for the transplant, because still we have to define a lot of things and we are not very sure about it.
Right. So, you know, you will do all those precautions which the surgeons are doing now. Like there are nice guidelines that are available by the ICMR for the surgeons, whether they're orthopedic, opthal, or liver transplant surgeons. The only problem I guess you people have to face is you have very long hours of surgery and, you know, keeping yourself in those very tight masks. That's all you need to divide your surgical time. That's what people have been talking about. So I guess you will proceed for this challenges that you're going to take. And in this scenario, that is a very important challenge with the entire team will have to face, because you will have to manage this patient in a special ICU, which is the post-transplant. You have to keep them in the COVID ICU. You have to keep your separate sisters, the monitoring, and the doctors being parked. So what we really do is that we keep the pediatric doctors who are going to be there, they are kept on rotation 8-hourly into the ICU, because it is not possible for a person to sit in that, you know, for 24 hours into that and into the PP kit. So we give them short 8 duties and we keep them for a week into that rotation 8-hourly, but they will not be looking into the non-COVID patients during that time who are going into that ward. So that is how we will be taking care of them. So now at the same time, now Mathur sir, both Bipin and Anurag have decided that yes, they have to take this patient to save the life, because INR is 6.5, the child will die and the child needs it. But the father is worried about giving you consent, and how will you talk to this father to allay his fear, because the COVID-19 is, so how will you counsel him?
You are giving the difficult job to me. Anyway, so the thing is that I think like any other counseling, now there are patients who has got permanent liver failure. If you don't transplant, what are the chances he will survive? Leave aside the COVID. Okay. So that is the point which has to be conveyed to the family, that if we don't transplant this patient, he is not going to make it. Okay. Or very, very rare. The COVID is incidental thing. Yes, COVID is likely to increase the chances of mortality in the post-transplant scenario. However, if you see the reports from the abroad, you will find that the patients who are being transplanted are not having high mortality post-liver transplant. It is the people who have been transplanted in the past, years back, are the one who, if we get the COVID, have got a higher risk. And my take on this, I think, Neelam, you can elaborate on that. It is the steroids which do the trick. See, that is the one which is used for treatment of COVID these days. Means definite drug which has been found to be useful. And all these patients, the post-op period, are on the steroids, which works for it. So that's how I think you have to convince.
I guess, you know, the saying is that what you get through experience in graying, you can't get through books. You are so on to the dot, because I think we are very fortunate that we are so many months down the line. If this transplant conclave would have happened in April, May, all of us would have said, we don't know how to counsel, what would we say? But I guess it is time which has really taught us. And in the world literature, there is no other disease with so many publications in that much month of time. So I totally endorse that. What I would have done to counsel this father is the child, as he said, would die without the need of a transplant. I mean, 95%, 97, whatever you take the King's College or, and say that the very high mortality, and say that we've not lost so many patients with COVID. And usually COVID severe disease treatment is with steroids, and that, as he's rightly said, is going to get. We, in fact, it is the staff, it is the doctors and the medical staff who are at risk, and they are happy to take. Bipin has agreed to do the surgery. So you should be applauding the surgeon that he is able to take, and rest, he will have a little extra facts that we need, because post transplant, we need to be monitoring the liver test and going to be looking at that. So I think that is what he would do to counsel the parents. Now,
I would like to intervene here, Dr. Mohan. I would like to intervene here. We are in the last 5 minutes of this panel discussion. Yeah, thank you. Just wanted to remind you, Doctor. Thank you.
So, Sunaina, I just wanted to know that you must be facing scenarios that when you are undertaking a diseased donor organ transplant, since you are looking into what are the challenges in this COVID era? Like when you get a call for a diseased organ, what are the steps you people are taking?
Dr. Mohan, thank you. Can you hear me?
Yes, yes.
Yeah, okay. So yeah, we get a lot of calls every month, over 100, only pertaining to organ transplant. So these are people who have just been told that they need a transplant, or that they're suffering from some sort of disease, liver, kidney, heart, whatever.
No, I'm not asking the recipient. I'm asking you get.
Yeah, so we are getting these calls. We are getting these calls.
For a donor.
Yeah. So they call us, and their main thing is they don't know what to do. They need a donor, or they need financial help. All right. So in terms of what to do, we can guide them. Of course, we can tell them this is how you do it. This is the process. You go to a hospital, you register, all of that. We even help them get an appointment. The thing that has really, it makes us feel really terrible and it's really heartbreaking is when so many people call up because they don't have the money for transplant. And that is the time over the last 7 years that we've been, getting calls. We just feel completely helpless. And I'm really happy to be here today because I wanted to tell you that during lockdown, we got a call on the 28th of May. And there was this guy calling from Kurnool, Andhra Pradesh. And just remember, we are the first people they call. But anyway, so he called and he said that his niece has liver cancer and that they've already registered in Apollo. So they had already gone to Hyderabad Apollo and registered over there. I think it was Hyderabad. They needed 40 lakhs for the transplant and the government had given them 20. But he was, there was not enough. They need 40 and they were, running from pillar to post trying to find it. And usually when we get calls like this, I also feel really helpless because, I know that, to fund a transplant is very, very difficult, especially such an expensive one. But for the first time, there was this glimmer of hope because I had attended the same conference last year. And then Kanchi had come to Delhi. We held a collaborative conclave of all NGOs every year in Delhi. And Kanchi had come last year from TPAF. And she had presented to all the NGOs in India. So I just said, okay, I told him the process and I said, okay, I'm going to call you back. And then we spoke to Kangshi. By the 2nd of June, we had connected Kangshi and this patient. And I think in August, first week, Kangshi called back and told us that they had registered the patient,
Great.
They had raised the money and they had got the 20 lakhs.
I appreciate your message. Dr. Mathur, I want to know which are the donor organs that you will, how will you as a doctor accept which organs and not accept which organs? Because with disease donor and you're going to check your COVID testing, there is a little difference in the COVID testing and the disease donor, we are supposed to check with bronchoalveolar lavage rather than a nasopharyngeal swab. So that was one step. And what are the other precautions you would take to take the liver of such patients who you think would have had a COVID 2 weeks back or 3 weeks back? So what is the protocol that we have now?
So Neelam, I will just elaborate on what protocol is being followed in all over Maharashtra in this regard for the diseased organ donors. So we have got 4-step screening process. The first is the epidemiological screening, and the epidemiological screening doesn't relate to that where was the patient. It is all the relatives who are in close contact.
Correct.
Followed by symptomatic
Clinical
and CT chest is must to rule out the asymptomatic variety. And then we don't have a bronchoalveolar lavage because
disease donor, right?
Disease donor, and we get the endotracheal secretion with the RT-PCR. So all the 4 has to be negative to say that the donor is a good risk donor for donating the organs.
Doctor, I would like to intervene and say that the time ticker has started. We have a Q&A also followed. So I would request Dr. Mohan if we can wrap up within this time.
Dr. Shrimal, you have treated some patients with COVID. Can you elaborate with the pediatric patients?
Yes. So we did around 10 pediatric liver transplants, and there were 4 very, very specific situations. So we post-transplant, post their discharge, 2 of our patients got COVID. Now, one was a kid with hepatoblastoma, and again, he has to receive his time-bound chemotherapy. So once this kid has just minor symptoms, he recovered in a few days and received chemotherapy. 3 more cycles of chemotherapy did well. The second kid I would like to discuss here is again a transplant. This was a kid with biliary atresia, had a Kasai done, and at the age of 12 now had decompensated liver disease and a regenerative nodule. So this kid post-transplant did well, and around 4 weeks from his transplant, around a week from his discharge, again got COVID. Now at the same point of time, his enzymes were going up. Initially, we monitored him, got a liver biopsy done, and that showed severe rejection. So we went ahead and pulsed this child, and again this child did well. There was a third case situation wherein we had a 5 kg kid post-transplant, and at day 6 or day 7 when we did the donor's discharge COVID, the father came tested positive, and then when we tested the mother and the kid, the mother also tested positive and the kid was negative. So we kept the kid with the nursing, with our own nursing support for the next 3 weeks. Sure.
Bipin, any experience of yours with such COVID pediatric patients, liver transplants, please?
Yeah, I don't have any experience because we did almost 5
Any other comment you want to give, please?
Dr. Vipin, there is a question for you from the audience. How frequently should the medical team of a liver transplant unit undergo COVID testing?
Yeah, so we basically do it before transplant and after 1 week after transplant. And so far our 2 doctors turned out to be positive because one of our patient pre-transplant was positive. But there is no guideline or written rule, but we do it for our own challenges and to face the transplants and all. And we had a couple of colleagues turn out to be very bad with the COVID. So we are a little careful about the COVID as of now.
So you believe in any prophylaxis or anything for your surgeons?
No. We believe prophylaxis to keep a healthy lifestyle and do whatever need to be done, not with the medicine.
And all that stuff. So before I wind up, I would like to thank the panelists. And if there is any pressing comment, I would request you all to please give the comment which you think you hadn't conveyed for the 3 questions that we were offered. We've completed them. But if there is any other comment from Mathur Saab, please, you want to have any other comment before I hand it over to Debajni?
Yeah, Neelam, I just want to comment on that with adequate precautions and screening of the donor and the recipient and all the surgical team and healthcare worker, I can share with you, at least in Mumbai, during this COVID period, we had 12 deceased organ donors. I'm talking deceased organ donors, from which around 40 organ transplantation happened. Unfortunately, none of the healthcare workers were positive, and also the recipients were not positive.
Very good.
And we followed every patient and everything for at least 28 days to cover the
that is a very important message that we still need to respect the organs, because a lot of people believe that liver is not so badly affected, and if there is being 2 weeks and 3 weeks post COVID positivity. So there have been different centers, which different countries, but on average 3 weeks is something that people have been talking about. So that was really a wonderful discussion by all my panelists who've done a wonderful job in communicating and giving the experiences, which is so heartening to share with each other. And I think we are dot on time, and I hand it over back to Debra.
Yeah, and Neelam, I thank you and looking forward to another holidays.
Holiday, please.
Thank you, ma'am.
Thank you.
Anurag, you were wonderful. Bipin, thank you so much. Nice to at least meet you virtually.
Yeah.
Thank you, madam.
Thank you, Dr. Neela Mohan, Dr. Surinder Kumar Mathur, Dr. Vipin Vibhute, Dr. Anurag Shrimal, and Ms. Sunaina Arora Singh for sharing your insights. And I really appreciate your cooperation that you had helped us to wrap up this entire discussion within the given time slot. Moving ahead, I would request Dr. Sonal Asthana to take this talk forward and introduce our next speaker. Over to you, Dr. Asthana.
Sure. Thank you very much. That was a fantastic session. Thank you, Dr. Neelam. That was moderated as only you can. You brought out the best of every panelist. I really appreciate how you managed to do that each time when we hear you speak. It's my pleasure to introduce the next speaker, Dr. Glenn Bonney. Dr. Glenn Bonney is a consultant hepatobiliary and liver transplant surgeon at the National University Hospital in Singapore, and also the director of the Surgical Proteomics Laboratory at the NUS. Dr. Glenn is here with us because apart from being a passionate academic surgeon, he has actually spearheaded a very interesting program in the times of COVID, which was a program of Telemedicine, a liver transplant seminars initiative about increasing the knowledge and using the digital networks that we have. Very quickly, I will, can you enable my screen sharing? I just want to show a couple of things. Now, can't see it. So essentially, is it possible to enable my screen sharing? No. Okay. So this is basically what Glenn had achieved in his first liver transplant seminars. He'd gotten together 28 participating countries and almost 500 delegates initially. And this has increased since to 42 participating countries. And in fact, the next talk is tomorrow. That is on the 7th of October, when he's got some of the world's leading experts in liver transplant talking. Please do attend if possible. This is, we look forward to hearing from Dr. Glenn about how he managed to put this together and the larger lessons of education in the time of COVID.
Thank you very much. Thank you very much, Sonal. And it's a great privilege to be here with the Pravin Agarwal Foundation, all its partners as well. Congratulations to the organizers, and more sincerely, congratulations to the whole team in the foundation and sponsors for the great work you're doing. I often say that India really, in terms of all its modeling for affordability in liver transplantation, as well as the results in transplantation, really is leading the world. And we learn a lot of lessons from India for this. I'll just share my screen. I've been given quite a big topic to talk about telemedicine and teleeducation, and I'll try my best to stick to the time limits. Right. So you should see that. Yeah. Okay. So first starting with telemedicine, I started with a background about changes in practice, some workflows, some practicalities in the future. So telemedicine is defined as the remote diagnosis and treatment of patients with telecommunication technologies, as we know. But importantly, this is a header published in the New England Journal of Medicine, one of our biggest medical journals, saying that recognizing that patients prioritize convenient and inexpensive care, in-person visits should become the second, third, or even the last option for meeting patients' needs. So if you look at a search on Google Scholar, a simple search looking at COVID-19 and telemedicine in the last year, you'd result with nearly 5,990 results. And so if you look at the market share over the last 6 years of telemedicine alone, there's been an average growth rate, annual growth rate of 34.7% year on year. And actually last year, this industry was valued at $45 billion US, and projecting forward to next 6 years is $175 billion US. So fight it as we must, telemedicine is going to be somewhere in the new norm, and I'm put together a little bit of considerations for this. In considering using telemedicine in the global pandemic, I think there are 3 objectives that we need to look at. First is for the remote and urgent screening of those who are symptomatic. The goal here being to diagnose, treat, and isolate those who are potentially carriers. Second is to protect those that are vulnerable, so our transplant recipient and donors that we have, and this is to limit contact of these individuals to healthcare facilities. And finally, it mustn't be forgotten that there's a societal benefit to this to reduce the footfall in healthcare facilities, therefore protecting your healthcare workers and the general population. So if you zoom that forward into the long-term effect of telemedicine, there's effects to the patient, doctor, and hospital. For the patient, obviously, it has huge implications on improving cost, time, and for large countries like India, the commute for the patients to the hospital as well. The downside is that obviously there's no clinical examination contact, but importantly, it requires IT savviness to some extent and accessibility. And potentially in the future, this may arise in a digital divisiveness that needs consideration. Secondly, for doctors, this has greatly enhanced time efficiency for us. It also allows for global reach. Singapore being a hub means that certainly that we are able to see patients much easier by telemedicine. The downside is that we lose that physical and emotional contact. I personally find it difficult, even just with a mask, consenting through patients, where you lose that physicality and the emotion of complicated discussions of transplantation and liver and pancreas surgery. And finally, for the hospital, of course, it's more efficient for the use of resources, but it has bearings on legalities as well as cost. So to address those 3 concerns, the first about remote screening. So this is one example done in Singapore. So there's an online website where it's specific to 6 different languages. You fill in the questions, including your postcode, and that then triages you into the severity where you need an emergency, suspicious cases where you go to a GP for a swab and you're isolated at home for 5 days, and non-suspicious cases. Clear messages are then broadcasted across many different social media websites, and this further enhances the ability to screen people. But perhaps what we are looking at more is about this protecting the vulnerable. So there's no doubt there's a need to, particularly when the numbers were high, decrease number of footfall in hospitals. So this is actually an example that we've had here. So on the left, we have patients who had in different subspecialties, so clinic A, B, C, D, E, different subspecialties in our hospital across a few months, across the viral pandemic. And here you have the number of appointments that we postponed intentfully after consideration of clinical needs across those months. So while these numbers don't look very big compared to large Indian hospitals, these are certainly considerable numbers in the National University Hospital. And then once again, you can see what that results in: a delay in the first visit appointment time. So where in November, the first visit appointment times would be about 10 to 20 days, it was tripling by March to April. So therefore, there really was a need to take up this slack in the form of telemedicine. So what were the lessons we learned from that? So what we did was the specialist goes through all the patients for the list that were in the clinic. We identify the patients needed, inform the clinic staff. The clinic staff contact the patients, get consent, discuss charges, and if the patient agrees, a text message is sent to them. If the patient doesn't agree, the specialist is then informed. At our clinic, we go through the documentation, request for the tests, follow up, fill in all the templates required for the patient, and importantly, document what's exactly discussed and send that on to the clinic staff, who then confirm the above, as well as some billing procedures, as well as follow up. Here's the data. So just under 50% of patients in orange highlighted here week on week reject the offer to have teleconsult. Just over 50% go on to do that. But importantly, why do they reject that? Just under 50% feel that they would like to have a face-to-face visit. That's quite understandable. But interestingly, a considerable number request that they don't need follow-up anymore because they're well. Some are uncontactable, and a very small proportion were due to have tests that they went on to miss and therefore would have had a pointless clinic appointment. So the message here was, yes, there is still a need for face-to-face visit from patients, but also the process of implementing telemedicine resulted in increased efficiency. And I have to thank my junior colleague, Yucha, for this data. So quite understandably, there are limitations with physical consultation. There's limitations with sudden adoption of telemedicine, which will gradually become more mainstream, and there's some manpower constraints. But importantly, this is culture specific. If we compare in the West, the take-up of telemedicine has been reported to be as high as 80%. It's also viral number specific. For instance, in country with very high viral numbers, the face-to-face visits have dropped to nearly 90% in some reports. And it's also specialty specific. So if you're looking at liver transplantation as we are today, it becomes more and more complex to discuss these things over a telemedicine consult. And therefore, there needs to be a consideration of expansion or contraction of programs. In order to address that, we tackled this by addressing a quadripartite ethical tension that exists to be able to contract and expand your programs in this publication recently in Journal of Hepatology. And for the limitation of time, I can't go through all the protocols we have in place specifically for liver transplantation in a pandemic, but we recently published this in the British Journal of Surgery, and this is the citation. The future means that Google have already started to look at just putting a search, which then joins in with maps, that maps you to a virtual clinic that is taken over by telemedicine. In Singapore, the government have worked together with Apple to create a new app for people's healthcare, vaccination, food hygiene, etc. Moving on to teleeducation. I caveat this by saying that I'm not covering medical students, I'm covering specialist data here, and I'm looking at the background, online resources, and the future. We all know what webinars are, and you can see that just in a PubMed search, just in the last year, there's nearly been a doubling in publications in webinars. And this is a previous publication that looks at the increase in plastic surgery publication since the viral pandemic. And you can see since the onset of the pandemic, a huge rise in exponential growth of webinars. The two main societies that govern and guide transplantation and hepatobiliary surgery is the ILTS and the IHPBA, and this is a reflection of the number of webinars that have come on board to educate us and share information across the board by the ILTS and IHPBA. I highlight in the center what Sonal just alluded to, the Liver TX seminar, which I'll briefly mention shortly. It's clear there's been an exponential growth. There's no doubt that it increases solidarity, accessibility, efficiency in time, cost, and personally, it also broadens the horizon. You attend things that you wouldn't necessarily go to physically. The downside is often can be unmoderated. It's not peer reviewed. It depends on IT facilities and access. It's didactic, and there's often lack of downtime fatigue and lack of social outings, etc. Just talking briefly about the Liver TX seminars, as Sonal's mentioned, this is a free, accessible online platform that we thought we'd put together, turn down sponsorship for, so that we could bring across the globe, lots of countries together to learn from the experienced groups of transplant professionals. To date, there are just short of 500 unique registrations, and now the registration's grown to 41 participating countries. And you can see some smaller transplant centers that are increasingly growing. We formatted it based on starting a program from scratch. So in using things like affordability, where Sonal spoke to, and then having Professor Avi Soin and Professor Peter Lodge talk about how they started their centers, and then building the infrastructure. Lots of familiar faces here, including Prof. Subhash Gupta, who shared a wonderful talk with us about the infrastructure of his center. Then we moved on to deceased donor transplantation. So we spoke about DBD and DCD transplantation by Anand and Prof. Paulo Moizan. And finally, I invite you all to our LDLT transplant symposium that will be tomorrow with two giants in the world of LDLT transplantation. Importantly, it uses a lot of social media, which is WhatsApp, Twitter, and we use user-driven feedback. So things like EV poll is another form of web-based education. So we can get user feedback on topics that they would like to cover to achieve this. And what's the future in teleeducation? Well, we've heard of VR and augmented reality, but perhaps one step forward of that is holomedicine. And so we're using holograms in medicine in a form of mixed reality. And this is currently being tried out here at NUH. So this is the HoloLens, which is the headpiece that we use. And just a short video to illustrate this. So this is the view through the headpiece. Through the HoloLens. This is a CT scan that has been rendered into 3 dimensions of a fractured skull. It allows the user to actually flip the fracture right the way around and expand it as needed. But importantly, it allows the user also to have views like this, where you're going behind the fracture, seeing all the bony fragments from behind in order to plan surgery. Clinically, this is also applicable in the field of neurosurgery. Here's a colleague of mine, Professor Yo Seng Sai, who's mapping the CT of a patient's brain, mapping a tumor directly onto the head for purposes of surgery, for surgical planning. And it can also be done with functional MRI, and these are neuron fibers seen through the head prior to surgery in order to be able to plan the operation, etc. And fortunately, I've got no graphic videos for this group. So I think with sticking to time, I shall move on to my summary, where it's clear that the current viral pandemic has exponentially increased the uptake of telemedicine and teleeducation. There are many platforms, some of which I've demonstrated here, that can be adopted to do this, that can increase the global solidarity and discussions that are needed at this time. It's likely to have changed clinical and education practices into a new normal. But importantly, that it's legislation, standardization, moderation, and transparency is needed in achieving this. When this whole pandemic is over, I'd really be very happy to welcome you to our little island. This is our team of transplant surgeons, coordinators, administrators, theatre staff, and residents. And I end with this saying from Socrates. Thank you very much for your attention.
Thank you so much, Glenn, for that really inspiring sort of overview of the future as it were. We don't have time for questions right now because we are about 12 minutes late. But I hope that we can pick up some discussions as we move forward. But thank you so much for that. Over to you, Debjani.
Thank you, Dr. Glenn. Thank you, Dr. Asthana. It was really nice to hear about telemedicine and teleeducation that is changing the medical landscape rapidly right now. And we really appreciate, Dr. Glenn, for you too, that you have invested your time for this webinar, connecting with us from Singapore. Thank you, Dr. Asthana, for hosting this talk. Okay, moving ahead for our panel 3 discussion, I would request Dr. Lalit Verma, who is a consultant in Department of Pediatric Gastroenterology and Hepatology at Wockhardt and Apollo Hospitals, New Mumbai, to take this talk forward. I would also like to remind our viewers that they can ask our panelists questions anytime they want, typing them in the comment section in YouTube. Zoom attendees can type them out in the chat box. If there anyone else who wants to ask from our Zoom attendees can also raise their hand and we will unmute them and take in the questions. Now over to you, Dr. Lalit Verma. Dr. Verma, can you please unmute yourself? You're on mute. Can you hear me, Dr. Verma? Can you please unmute yourself, Dr. Verma? I think you're on mute. We are not able to hear you. That's the topic for panel 3 discussion.
Now, coming to your question about awareness about biliary atresia, so there have been countries which have introduced biliary atresia. For those who don't know, is a condition where you don't have the bile ducts developed and the child presents with jaundice at birth. And the best way to diagnose it, just screening way to diagnose it, is to look at the stool color. So I think it is important to train the doctors and the mothers to look at the stool color. And if it is a light or clay colored stool, there are stool charts which have been formed, and countries like Taiwan have led the way, where they give the abnormal 6 different types of stool colors, and you say, okay, if it is any of these 3, then it is likely to be biliary atresia. So just hand over the chart to the mother, train the doctors to look at the stool of the child every time, not just tell them what is the, not just ask, but look at it yourself to confirm. So this way you could pick it up early, and the reason is that it is a very treatable disease, one of the very treatable disease. If you operate a child of biliary atresia within 2 months of birth, then they are likely to do well and not need a transplant.
So, Dr. Rao.
Severity of illness at the time is relevant. It predicts the immediate survival of the patient, which you're already achieving in excess of 90%. So that factor is very valid. I think what is missing is, after they have had the transplant, gone to their own place, it's the multidisciplinary approach, attention to detail. Attention to detail, I mean looking at every single blood test very, very carefully. And that's where I think the problem is. The compliance issue, when I speak to people in India, your patients' compliance is no, our patients take medicines. We are all humans. Let's accept it that human physiology, psychology doesn't differ. So I think it's the aftercare that is lacking at the moment. And that Naresh made a point in his talk that, the local pediatrician, local doctor, so that's where we need the networking. It could work. I think you need to identify few pediatricians, not everybody.
Welcome back, Dr. Verma. Handing over this talk to you.
Yeah, thank you. There might be a double echo sound. Apologies for the technical glitch, but I just checked and I was all set, but sometimes it does happen. So a very warm welcome to all of you, all the panelists, and so far it has been a great day. It's been a long and insightful day with various experts and knowledge leaders from across the globe sharing their perspective on pediatric liver transplant. I hope everyone has gained enough wisdom on the subjects and its nitty-gritties. We will now talk about adapting to post-operative care of pediatric liver transplant recipient and the donor, complying Okay. So our first panelist is Dr. Subhash Gupta. He's the founder chairman at MEC Center for Liver and Biliary Sciences at MEC Super Specialty Hospital, Saket, New Delhi. Next on our panel is Dr. Rajiv Lochin. He's the consultant liver, pancreas, and transplant surgeon at Integrated Liver Care Group, Aster and Aster CMI Hospitals, Bangalore. We also have Dr. Sheetal Mahajani. She's the director and transplant of hepatology department of gastroenterology at Sayadri Hospitals, Pune. Also the founder liver care clinic director of Pune. Then we have Dr. Naresh Shanmugam. He's the Director of Women and Child Health Pediatric Hepatologist and Gastroenterologist at Dr. Vela's Institute, Chennai. My first question is open to all the panelists. Can you hear me? Am I audible?
Yes.
Yes.
Okay. So my first question is for Dr. Gupta. You know, we are in this pandemic. This is not the first one, nor it will be the last one. But what are the guidelines and practices that are being followed for the home care after the discharge of your liver transplant patients that are being followed by your center?
Thank you for having me, and I'm as usual grateful to Pravin Agarwal Foundation for helping so many children to go through their transplantation. The pandemic has been really difficult. Is that not only we have to plan, do the operation properly, but also ensure that pre-operatively and post-operatively do not have non-transplant related complications. So as a result, what has happened in our center, and we do a lot of transplants. I think last year we did over 100 pediatric transplants, and last 2 years we did over 100 pediatric transplants. And what this has meant is that patients, once they reach us, we try and keep them within the hospital. And once they go through their successful operation, we try and keep them in the hospital till they're completely well to be released to go home, because we don't want them back. We don't want admissions after discharge. So what we ensure is that there are no pending issues. That means if they need a CT scan, they don't have any MRCP, biliomas, biliary strictures. We will even do a HIDA scan to ensure that they do not require readmission for any of those things. Then we'll ensure that they learn their medicines. We teach them how to fill a chart, so the chart which they can share with us through the net or through WhatsApp, so we can guide them what doses to take. So we try and minimize as much visits as little visits as possible following discharge. And they've learned everything in the same admission, which previously we were doing differently. Previously, because once they were well enough, we had discharged them, because we thought that, even if they required readmission, we could readmit them again if they would ask them to live nearby. Now, in the pandemic, what we do is once they're well, they are actually well to go home completely. Then, if they require the visit to the hospital, we get them straight to the liver unit, which is on the 4th floor of our hospital, where a dedicated team will look after them, so they have no waiting in the hospital common areas. There'll be a phlebotomist who will take the blood in the in the 4th floor itself, in the liver unit. Finally, the one major change that has happened in our pandemic practice, that laparoscopic donor hepatectomy has taken a backseat, and we try and tend to do most of these open donor hepatectomies for these children. So these are the sort of guidelines that we've done for post-operative care. Then ensured is that we have a local pediatric doctor. You heard Dr. Anil Dhaban, who's a great friend of mine, to suggest that there must be a liaison work with local pediatricians, so that if there is a problem, it can be sorted at home. So communication needs to be established between the recipient, between us and a local pediatrician. Availability of drugs was a problem during the pandemic, and we gave them our numbers. We liaised with pharma companies, and whenever that has been a problem, they have delivered at the doorstep. And our coordinators have been on the phone with the patients to ensure that they've been taking their medicines at the right time. If So these are the things that we've sort of ensured quite differently. And to summarize, they have a longer hospital stay, not because they have any complication, but we're scared of readmitting them, which sometimes can be disastrous coming to emergency. We make sure that they learn the medicine, learn everything in the same admission, so that if they were to, they do not have a problem once they're discharged from the hospital. The steps we've taken.
Thank you. I'm logged in actually with two networks, so there might be some concerns here. But my next question is for Dr. Naresh.
Yep.
Naresh, you have been doing transplants, especially the pediatric one. What if in the worst case scenario, you're faced with your recipient who turns out to be COVID positive post-transplant? What are some of the symptoms to watch out for, and what are the necessary interventions that you do in that case?
Thanks, Lalit. And I would also thank the Pravin Agarwal Foundation for having me here. I think whatever question you have asked, I think in the previous session, they have discussed about donor issues, what happens. So I'm not sure whether we need to go into it again about the donor issues immediately after surgery. I think we are looking into issues that happens after surgery, how the logistics work, what are the guidelines, and how things are to move forward. Unfortunately, COVID is a new disease, and it didn't give us time to develop a guideline when it hit us. It hit us in March, and none of us are totally aware of it. And when it hit us, essentially all the hospitals are functioning in full capacity. So when the government lockdown went in, there were like all the hospitals are nearly in full capacity, and the patients were all around, and it was quite chaotic at that time. And also at that time, the government policy of tracking the COVID person, if somebody who has come into the hospital and then found out that he is positive, then I think essentially the hospitals have been shut down for 2-3 days to cleanse it. So it put a lot of pressure for us to improvise how to make things safe in a short time, how to educate the parents, how to move things ahead. So here because at the time the people were not aware of the severity of the illness, so a lot of education, sudden hospital shutdown, people coming from all over the world stuck in hotels. So a lot of arrangements has to be made within the hospital. So emergency, we used to have daily meetings about how we could organize things so that patients doesn't feel the burden on them that they are left out. So we organized home collection so that people doesn't need to come in. So we categorize the patients, and we essentially sent because most of the immediate post-op patients stay around the hospital. We send the person to collect it, and then the samples would be run for the test, and then we do a teleconsult. So that was the scenario in April, May, and June. But then during April, May, and June, the number of transplants fell down. Now we don't have that many patients around, and now we are much more educated. The patients are also much more educated. Awareness about cleanliness and all those things are there. So at present, the situation is much safer for going ahead with transplantation.
Thank you. Okay, my next question is for Dr. Lochin. What are some of the medication and travel considerations for the patients?
Thank you, Dr. Verma. I must say that this is actually one of the most important aspects of postoperative care of children. I think especially this pandemic, what it's done, in addition to what Professor Gupta and Dr. Naresh just mentioned, one of the most important things that it has done is actually to isolate the society and the societal support which a child and the donor, get. Essentially, because we are worried when we discharge them back to the community, whether they will get the COVID from the community, transmission that is so rampant now. See, in our unit, we run 3 hospitals in the south of India, 2 in Bangalore and 1 in Cochin, and we've done 8 pediatric transplants during this COVID time. And as opposed to the other large groups of transplant units in India. Our patients are actually from within Karnataka, within South India. Our international patients has only been 1 out of the 8. So our challenges are very difficult ones to actually surmount. Most of our patients are rural patients. They are from middle class, low middle class families. Their access to telemedicine or teleconsulting is actually very limited. They rely on a lot of social support to, get them through difficult times. And surmounting one of this has been our biggest challenge, especially getting a simple tacrolimus level done in the remote parts of Gulbarga or maybe Satna in Madhya Pradesh has been a big challenge for us, So, pharma companies have helped a lot. Our connections with the Rotary clubs have helped a lot. Our mutual connections with the referring doctors have helped a lot, sending, them to a friendly lab to collect the tacrolimus level and the sample to be sent to Bangalore for the test to be run. Or for example, in Gulbarga, because the transport to Hyderabad is not available. So these have been the real life problems that we have had to sort of, manage. Of course, there's a lot of things we are learning the plane as we, we're learning to fly as we're sitting in the plane, really, that's what we're doing with the pandemic, regarding immunosuppression and things, moderating the immunosuppression, and especially in people who have caught COVID. Thankfully, none of our pediatric transplant recipients have caught COVID. One of our adult patients, around about 24, 25, young adult did get it, but he had quite severe COVID, but he's managed to recover very nicely with standard treatment and reducing the immunosuppression levels. But thankfully, he did not have a significant, liver injury. But I do know that other people have faced liver injuries in their patients. So I think the societal challenge and the societal isolation has been the biggest challenge for our patients, especially for our pediatric transplant patients, really, to surmount.
Thank you. I'm trying to speak less because of the echo, but my next question is for Dr. Mahajani. What is your take on a telemedicine consultation versus bringing the patient physically into the clinic, especially like say 3 or 4 weeks post-transplant?
Talking about the post-COVID, post-liver transplant management of these patients through the COVID pandemic, there are a lot of challenges. Now, getting them to the hospital for regular checkups sometimes creates a lot of panic within the families of these patients as well as within our minds, because these patients will be traversing through the common waiting areas of the hospital. And now all of us know that every hospital has COVID and non-COVID areas. So it becomes a big challenge. So what we have been doing so far is the essential visits are only they are encouraged to come to the hospital if they are unwell and we need to check on them physically. Otherwise, all the protocols have been very clearly translated to all our post-transplant patients. And there have been WhatsApp groups for every patient where the coordinators, doctors, the entire team is on that WhatsApp group. So what we do is we have given them a timetable of their routine tests, their tacrolimus levels, and their medicine prescriptions. And if there is any issue wherein we need to see them, then only we call them back. Having said that, I have had almost over 15 patients who have had liver transplants in the last 2 or 3 years, and they happen to become COVID positive. Now, what I can tell now from my experiences, tacrolimus and steroids both kind of give them some protection against the cytokine storm, which is the most concerning or worrying thing of COVID. And most of them have had home treatments through their COVID positivity. Only one patient between these 15 have had remdesivir. And none of our pediatric patients have had COVID. These were the adult patients. However, one of the living donors contracted COVID through the visitors who, like, she was in the hospital, and I think somebody gave her COVID. That was a nightmarish thing. However, she also sailed through this COVID infection very cautiously. Ever since, what we have started doing is we are restricting entry to these recipients as well as donors, and whosoever is going to give them the care in the immediate post-operative period, we are encouraging to get their COVID status checked.
especially if we are providing a nursing attendant with the patients, the recipients after discharge, then definitely those attendants' COVID status is known. And we encourage them not to intermingle with other relatives and visitors so as to keep their COVID possibility at a very low level. But it has been all through a big experience and knowledge imbibing to us as well, because we never knew at the beginning. Like all of us will remember that the first month of COVID, that's especially March and April, all of us had stopped transplant activity, thinking that it's going to do really bad things to our patients. But then we all started realizing that more and more patients are dying because of their liver disease than COVID, especially those on the waiting list. And now then we realized that we have to take all the precautions and go ahead. And I think that is going to be the norm even for minimum 1 year to come, because we see no chances of this COVID going down. I am in Pune, and you all know that Pune has become really the hotspot in the entire country, and our numbers are huge. We have a lot of challenges, but then I am also, as a member of ZPCC Pune, can proudly tell you that we are also going ahead with cadaveric donors by taking all the precautions, and so far so good. So all the government guidelines are
Thank you,
being
Dr.
followed.
Mahajani. Sorry to interrupt, but I think we are running short of time. I just want all the panelists to give that one line about how to go ahead with the COVID scenario and how to be safe. One advice that you give to your patients and all the other doctors taking care of the post-liver transplant patient, please. Starting with Dr. Gupta, please.
Before, as Dr. Sheetal said, even if you get stricken by COVID because of whatever reasons, you will not become seriously ill. So need not fear too much about COVID in the post-operative period.
Dr. Lochin, please.
I think the only thing I'd like to say, I mean, this is mainly towards the pediatric transplant families and patients, pediatric and families with children with liver illnesses, is wear your mask. I think that's the most important thing that I'd like to tell them.
Naresh, please.
Yeah, I think a lot of parents are watching this, so I'd like to give some advice for them. Essentially, though there is a COVID and non-COVID area, it doesn't mean that there is no COVID patient in non-COVID. I think potentially anybody could be a carrier. So think before going into the hospital, only necessary. And the appointments in our hospital, we made a policy that nobody can stay more than 15 minutes. So they come right on the time, see the doctor, go out. Cafeteria is closed, so no chit-chatting around. Don't give the investigation going around and sort of family chit-chats with other patients sort of going around. So meet the doctor, get your prescription, and walk out of the hospital. That's the advice I would give to the parents.
Last, Dr. Mahajani, please, online.
Yeah, 4 things are important: social distancing, wearing masks, hand hygiene, and make use of telemedicine as much as possible with a lot of prior education. I think that's the key forward.
Thank you all. We have covered all the aspects almost of the post-COVID care required. Sorry, some technical glitch just like this COVID, very uncertain. But thank you everyone, all the panelists, Dr. Gupta, Dr. Lochin, Dr. Mahajani, and Dr. Naresh Annugan, for being a part of this excellent panel discussion. Thank you. Over to you.
Thank you.
Thank you, Dr. Lalit Verma. I know there was so much to discuss and so much to share, but we are really pressed for time. I would once again like to thank Dr. Subhash Gupta, Dr. Rajiv Lochin, Dr. Sheetal Mahajani, and Dr. Naresh for sharing your insights with us at ALTC 2020. Now, I would request Mr. Ayan Chatterjee to take this talk forward and start with the next panel discussion. Mr. Chatterjee is the Honorary Operations Advisor of the Pravin Agarwal Foundation and is currently heading the Sterlite Ed India Foundation. Over to you, Mr. Chatterjee.
Very good evening to all our viewers and members of the panel. It is really great to meet all of you virtually among us. In the earlier sessions, we all gained knowledge and insights which were primarily medical in nature. And I would like to lighten up this part of the story and invite my distinguished speakers to talk about cost effectiveness. So my first speaker is on the panel. I mean, while we understand various aspects of liver care, advances around the world. In the last leg of this webinar, we are planning to discuss costs, and I bring Dr. Shenoy. Dr. Shenoy Robinson is a thought leader to the healthcare industry. He's been a chairperson CII's Technical Committee on Health, and he's on the board of advisors for Rishihood University. He had also been a chief medical officer with Delhi government and had been a group CEO for Apollo Hospital. So I would like to see how he can bring his expertise and his experience on drug inventory, cost structures, and the balance, the fine balance which a hospital administration have to make between profitability or financial sustenance, as well as the intent to help the patient. I will be looking forward to those inputs from Dr. Shenoy. Next, I would like to bring a very strong advocate on patient needs, Mr. Sridhar Hanchinal, Honorable Director of Mohan Foundation. Mohan Foundation, as we know, is synonymous with the awareness efforts around the wonderful cause of organ donation and encouraging India to be part of it. Mr. Sridhar retired from the sales function of Novartis. I'm sure he got a ringside view of the generics and the evolving drug and formulations impacting the transplant ecosystem. And post-operative immunosuppressants is often a lifetime cost and a very major worry, because we have often in TPAF found, families bothering about in the second year, third year, how they will financially support the cost. So I'll be looking forward to inputs from Mr. Sridhar on various aspects his experience has gathered. Next, I will bring Dr. Verma. Is he there? He's has been in Europe, and I'm till last we didn't get a I think technical this thing. So I will just if he's there, he will join us. Otherwise, we'll move to the next panelist. Dr. Verma, as just to introduce, he's the head pediatric gastroenterology and hepatology part of Max Hospital, and he's been very active advocate of transparency in success ratios within the hospital environment and various hospitals, how successful they have been having. That data is very well shared by Dr. Verma, and he's been a strong advocate of that. I move to next, a very dear friend of mine, Mr. Anuj Vishwanathan, co-founder and president of Milap, the top crowd fundraising platform in India. And the World Bank crowdfunding support, the report of 2019 indicates that developing world has the capability to deploy up to $96 billion a year by 2025. And the China is one of the leading countries around crowdfunding, and India has a long way to go. Milab has been one of the first pioneers in this, and recently on 15th August, I noted one of the dreams of Anuj to bring free of cost do-it-yourself campaign succeeded, and now on Milab and some other platforms now which mimicked it, we have a free of cost crowdfunding option. And crowdfunding has been a big support in this context of where finance often plays a key role in the decision. And last but not the least, I'm happy to bring Anita Puranik, the founder and CEO of MetaMagics Software. Its solutions include a platform with a range of offerings, and she will bring the technical and the data analytics and machine learning perspective to the discussion. Welcome to all my participants. So now that we have been acquainted, we are running short of time, so I will try to manage the time. Please bear with me. But I'll try to bring in the best perspectives around cost effectiveness, and the questions will be relevant to that. And we have 15 minutes, and I will jump right in. So if we look at cost for a liver transplant, it is a high cost activity spread over a long time. Pre-transplant, like the diagnostics, consultation, etc. The actual transplant cost, where we are actively working, and the post-operative cost, and the long-term sustenance cost, the immunosuppressants, etc. So I'll bring in Dr. Shenoy's perspective here. Is there any way the ecosystem can offer less cost in the pre-transplant phase, for example? What are the best practices which you would like to highlight? And I know that you have been advising PE and VCs around various strategic aspects. What are the ways to save time and resources for a patient family, if you can bring in that perspective?
Thank you so much for the intro and the chance to talk here, Mr. Chatterjee. I would like to approach this cost effectiveness from a very different perspective rather than going by the way we've always been. So first level, when you look at reducing cost across board, is create scalability. If you have large volumes, naturally everything becomes cost effective. Now, when you look at scalability, we are looking at, and this is something which every liver transplant team in this country is also looking for. Can I get more patients? Can we, use more cadavers rather than wasting cadavers? So imagine that you have a big pipeline. Now we have transplant registries, but they are not adequate. Imagine having a pipeline of patients who are being monitored actively by hepatologists prior to get and preparing them for a transplant, which is absolutely clinical. This is nothing to do with technology. Technology will be a platform where patients can come, register, upload their reports, get advice from doctors, maybe their own treating physicians in their towns get supervised by hepatologists and transplant hepatologists sitting in bigger cities. And this ecosystem needs to not just evolve, but actually grow. Unfortunately, today we are working in silos. Every hospital works, within their own transplant team and trying to get their own network. Now, if we just, got together and created a bigger platform of telemedicine. When I say telemedicine, just bear with me. I know there's been a lot of talk on telemedicine, but that's the place where you will reduce cost. So you create a big pipeline. Doctors are connected, patients are connected, they are being monitored pre-operatively. Next, you have the surgery done, then you go home. Now it's about follow-up. Just imagine a similar scenario where there is an ecosystem which supports the patient to follow up, whether it's to do with diagnostics, whether it's to do with consults. It's really not required to come to the hospital so often. I mean, I deal with all kinds of transplant patients or transplant programs talking with heart transplant. Yes, in the first few weeks, heart transplant requires a lot of biopsies. Liver transplants don't. So net, what I'm trying to say is telemedicine, instead of just being teleconsult, should become much bigger, which it is. So for our company, for example, provides all that. This solution is more about monitoring. It's all about patient engagement, educating them, giving them reminders, giving them education about what to eat, when to eat, giving them consults, not just with the hepatologist or the transplant surgeon, but with the nutritionist, with the psychologist, with everybody. So, any platform can do that. Any agency, any not-for-profit organization can actually gear up. It's not very expensive. It's just the will to do it. So that's my first understanding of how to reduce cost. Maybe when you listen to other panelists, you can come back to me and I will talk about more about direct costs and indirect costs.
Sure. Yeah, that will be very interesting. I'm very keen to learn about that, and I'll definitely come back to you. But what in summary, you were saying that the telemedicine is only very minimally explored, and it has a long way to go at the various patient life cycle, both pre and during and post. So thank you for that perspective. I'll jump into the fun part, because across the last few sessions, we also understood that, yes, the medical aspect is advancing, but one of the key determinants from the patient family, and only about 10 to 15% of the patients actually get a chance, the right finances to have the transplant. And the rest 85% probably cannot come in because they don't have the finance. And that's where TPAF is also trying to collaborate with other partners. The crowd fundraising has often brought in the requisite fund to the family in the nick of time. And I'm bringing in Anuj to the discussion. We also saw that the crowd fundraising has had, standardization. It is looking at ways to induce more information to the patient. And we also see a range of crowd fundraising targets, which often, bother a lot of the ecosystem stakeholders. There is something which we are raising at, let's say, 15 lakhs, someone raising 25 lakhs for a donor. I'm a retold donor. I would be bothered that how do I contribute 300 rupees or 500 rupees, and will it reach the patient? Because for me, I want to donate and I want to realize value. Bring in your perspective around this, and what are the ways, what are the key concerns you are it's high on your agenda, and if you can use the forum to express that.
Sure. So we've been in the crowdfunding space for the last 10 years, and specifically on the healthcare side for the last 6 years. So we started, healthcare primarily as a result of, people wanting to raise money for medical treatments, specifically tertiary care. And that's when we realized how the out-of-pocket expense, India has one of the largest out-of-pocket expenses, and relying on friends and family has been a sort of a norm over the years whenever there is a tertiary care requirement, so to speak. So far from our experience, specifically to the question around standardization, one of the things that we learned very early on is to make the information as transparent as possible to the donors, right? And let them make the decision when it comes to contributing, so to speak. Which means our role as a platform will be focused on two things. Does the patient actually exist, right? Do they actually exist? And does the need actually exist? So these are the two things that we have fundamentally focused on as a platform. Because in a country like India, where you have, even for tertiary care, you have a range of institutions providing it, right? From government hospitals to charities/trust hospitals to private hospitals, etc. One of the things that we realized very early on is not to become a sort of a big brother in terms of saying that this is essentially what the cost would be and this is not. What we would of course do is to ensure that we verify whether these are actually coming from the hospital or from the treating doctor, and making it available, accessible for public, and also allow public to ask questions if need be, right? And that transparency, I mean, we've facilitated crowdfunding for over close to 80,000 patients thus far over the last 6 years. We've mobilized around 600 crores of crowdfunded capital for these needs. And we've realized that the donors understand that the cost of treatment varies from one hospital to another. Of course, you will also see the wisdom of crowd playing out when it crosses a certain threshold, because if many donors come back to asking it, and the way they essentially say that this is not something that they want to fund is to actually not put their dollar to that need, go ahead and fund it. Having said that, one of the things that we've done as an organization is, while we are a do-it-yourself platform, we allow people to raise money free of cost on the platform. We provide the tools, etc. We also realize that there are patients who come from, financially disadvantaged backgrounds, who may not have digital literacy, so to speak. And when it comes to supporting them, we go the extra mile in telling their story on social media, etc. And in those scenarios, we do have some sort of guidelines in place in terms of what should be the cost of treatment, how much could it go beyond, what is it that we would be able to put it out there, because at that place, it's essentially not just the hospital, but also the MILAP's reputation, which is at place. So that's one. So we do that for probably 7 to 10% of the patients, but 90% of the time we let both the patients as well as the donors make an informed decision.
You let the market decide.
Yes, and our role is to be as transparent as possible in providing the information required.
Sure. And I think going further, I mean, there are more possibilities of transparency like success rate or other data which probably we mutually can decide, and we can bring that information to the patient, to the donor community. Bringing in Mr. Sridhar here, he had been long with the medicine industry, earlier drugs and formulation, and now a major advocate in the post-retirement to the Mohan Foundation. Part of the thing is bringing the patient, identifying the patient, getting the right diagnostic, moving to the transplant, but also to sustain the patient, because the 3-year cohort figures, what we understood from the earlier scenario in Los Angeles, it's moving between 97 to 100% success, but it's much lower in India. Can you bring in your perspective that what are the ways a patient family can look at the right way, or can we help as an ecosystem the patient family to bring in the finances or some other ideas which you can bring in to make it more cost effective for the long-term sustenance?
Thank you, Mr. Ian. Thanks to Pravin Agarwal Foundation for bringing me as one of the panelists. And going forward, thanks to the government policy of bringing a lot of medicines under the NPPA, so effectively as compared to in the 10 years back and now in the last 5 to 7 years, the price of the medicines have been rationalized, I would say. But however, especially when it comes to the transplant, where the patient has to take for lifelong, it is very important that the consistency has to be there for the patient's funding, money availability. See, if you look at uh, the pharma industry per se, who are players in this space of transplant, there may be about 7 to 80 transplants companies are there, products are there. I mean, companies marketing these products, but very few have the patient support program. But to get the product into the hospital pharmacy, that will not be a factor. The other factors are different, and these players are not, they are regional wide players are there who are dominating. So coming back, it is very important that all the companies who are in the transplant space should have the patient support program. What I mean in that is they must support the drug level, which is a very important parameter for the post-transplant care. Second thing is, even if it is not possible, it's not possible for all the tests to be taken care. Doesn't matter, partial. But all companies who have transplant products should have the patient support program. Second part of this is the adherence for the there needs adherence for the counsel. I mean counseling for the adherence, because once the transplants, immediate post-transplant patient and the family will be very careful. But over a period, when we see, when I do the counseling for the patients, transplant recipients rather, I do find some sort of complacency comes in. One. Second thing is the cost of the therapy also becomes a problem there. So patient support program should be in such a way that in a period of a year, at least 3 to 4 times patient should get something free medicines. So that will make the patient to continue the medication. I think that will make a big difference for the families to take care.
Sure. Thank you. Thank you for your perspective, Mr. Sridhar. I'll go back to Dr. Shenoy for the one last bit. We are pressed on time, and there are other guests for the next panel coming in. But I understand it, since being a CEO of Apollo Group, I mean, it was a major hospital administration experience and challenges. So can you bring in some other aspects which you alluded to? Like one was, of course, telemedicine coming in a big way and expanding it. But what are the other things which come back to you, which can help make the whole experience more cost effective?
So when you're looking at costs, basically they are looking at, when you look at a hospital's costs for a particular kind of specialty or surgery, we are looking at direct costs and indirect costs. Now, when we're looking at direct costs, what we are looking at is what is the surgical fees or the doctor's component. The second is the meds that go into it, and third is the diagnostic. I mean, you can even put in diagnostics in a package, but these are like direct costs. Indirect costs will be the hospitals, fixed costs that are there, which we try to offset.
Rangy?
Now, usually in transplant cases, the direct costs are pretty high. It will be more than 50% in some cases, which means that our that means our gross profit or our gross margin is less than 50%. But because the ticket size is so big, we are able to manage the fixed costs also and make it quite profitable.
Sure.
So the key.
I'm sorry to interrupt. I'm told by the anchor that we have just 1 minute to summarize. So because the next guest has come, I'm sorry to interrupt. But Dr. Shenoy, please carry on and just summarize the part.
So what I was saying is the key is not in tweaking costs so much as managing those major cost heads that are there. The diagnostics, the surgeon's fees are not too much. It's the diagnostics and the meds. Sure. Now these can be reduced through third-party interventions. Do not expect individual hospitals to do it. Third-party, like your crowdfunding, similarly, you should actually crowdsource tests and meds in an NGO environment, and I think that would seriously bring down the cost.
I think that's a key takeaway in terms of diagnostics and medicines, how we can collaborate as an ecosystem. Thank you so much. I really appreciate your thoughts and this thing. I'm sorry I couldn't continue this discussion. We'd love to have you again. Back to Devjani. Thank you to all the panelists.
Thank you, Mr. Anand Chatterjee, Dr. Shana Robinson, Dr. Sridhar Hanjinal, Dr. Sharad Verma, Mr. Anuj Vishwanathan, and Ms. Anita Puranik for sharing your point of view and time with us. I would now request Mr. Pravin Agarwal to come in and welcome our guest of honor. Over to you, sir.
Hi, everyone. Once again, welcome for this TPAF on web seminar. I'm very pleased to inform the entire audience and panelists and the doctors all around the globe that we have a chief guest of the evening whom I have a privilege to welcome for the event. I don't think so I need any formal introduction for the gentleman whom I'm going to share with all of you. Especially during the COVID period, most of us have heard so much about him and his contribution to the humanity and in general has been amazing, and the contribution has been so I felt that no one could be a better person at this point of time during the COVID period and to have a guest of honor with all of us and say a few words among us. So he's Mr. Sonu Sood. And we all know about him that he's in the last more than 2 decades in the film industry as well as the producers. He worked more than 5 different kind of languages, Indian regional languages. Other than Hindi, he has been worked in Telugu, Tamil, and Kannada and Punjabi movies around. Also, friends, most of the time we know that what we see the bad image on the screen, but in the real screen, he's a real humanitarian in the real life. And exactly the same we all can see the person in the real life is the much more than a humanitarian and the person what he does for the entire social and improvement of the life and the supporting of the life, especially during the period. And that is the person is among us today. Also, one of the biggest, we all saw that Sonuji has helped migrant worker, and that was the biggest support for the entire ecosystem at that point of time. More than 1 million people were almost on the road, and no one has any idea how to get the support, how to give them right how they can reach to their hometown, their village, wherever they had, because of the very difficult situation. And at that point of time, all ecosystem was worked with Sonuji, and he supported entirely to make sure that the person they reaches home safely with their supports. And also, I'm very pleased to share that Sonuji has received in this last September, and he was chosen the most prestigious SDG Special Humanitarian Action Award by the United Nations Development Program for his humanitarian works during COVID-19. I would now request Dr. Sonuji to please share a few words with us. Thank you.
Hi, everyone. First of all, thank you so much, Pravinji, for introducing me to your family of all these rock stars. I call them rock stars because they are the ones who bring so much of change in the lives of people who are in need of help, in need of some kind of guidance. And I remember the first time I spoke to you, I felt a lot of confidence because, I was, when I started my journey of sending these migrants home, I'm an engineer. I never thought that, I knew any way how to send them back. There was no formula that I knew, but I just had that zeal to send them back. I stayed away, I was distributing food at Thana in a place called Kalwa Chowk. And when I saw these 300 people walking back to Karnataka on foot with little kids, so I said, just stop, just give me a day or two and I'll get some permission sorted for you. Went straight away to the police station, got all those guidelines done, spoke to the different states, all the states that adjoining states and all. And I realized that there can be a formula where I can send them back to, their natives. And, and that was the first time when I'd sent those 350 people back to their homes. And when I was there at the bus stop to see them off, everyone had tears in their eyes and smiles on their faces. And they said, we never realized that, we are going back to our natives, and we thought that, we'll die in this city. And then I realized that, this is not a story of these 350 people, but it's a story of millions of people who are stuck, who want to go back to their homes from Jammu Kashmir to Kanyakumari. And I said, now I have to make that happen. And then I, started getting connected to different states, different ways, whether sending them by flights, whether sending them by trains, whether sending them by buses. So I realized that, when I started the whole process, the doors started opening, and I believe that, it's all because of the prayers of those families who are waiting for their loved ones to come back, the mothers, the parents, the wives sitting in Bihar, UP, Uttarakhand, Jharkhand, every state. So they were praying for the kids to come back. And those prayers were I would say, that gave me power to actually, send them back to their homes. And, I could send more than 2 lakh people, close to 2 lakh people. I was connected to almost 7.5 lakh people during those times. And I thought, sending them back home, my job is done. And I always used to ask them, ki yaar, aap wapas to aoge na? And they used to say, ki सवाल है कि इनको काम कैसे मिलेगा? And and I thought कि इनको काम दिलाना चाहिए. Then I started giving them rozgar through Pravasi Rozgar, and we could generate close to 1.5 lakh jobs in different parts. I got connected with different Trident, Amazon, lot of companies and all. I said, चलो यार jobs का काम हो गया, अभी कुछ नहीं. But these people who are living in these states, they realized कि सोनू अगर हमें घर भेज सकता है, हमें जॉब दिला सकता है, तो अगर हमें कुछ मेडिकल प्रॉब्लम आई तो ये भी सोनू ही दिला सकता है. सबकी प्रॉब्लम्स आनी शुरू हुई कि मुझे हेल्थ की प्रॉब्लम है, मुझे बच्चों की हार्ट सर्जरीज करवानी है. तो मैं I had few friends who were doctors but never actually knew so many of them. और मुझे पता नहीं था कि मैं कैसे इन लोगों से कनेक्ट करूं. But I started calling them and I thought कि चलो करते हैं फोन. And one doctor said, कोई बात नहीं सोनू भाई, आप भेज दो, I'll get that surgery done. उसकी सर्जरी हो गई, वो ठीक हो गया. फिर दूसरे को फोन किया, उसने किया, उसने अपने दोस्त से मिला. So एक चेन बननी शुरू हुई जिसमें मैं almost 10 से 12 सर्जरीज रोज करवाने लगा. From people from West Bengal used to go to Karnal, कोई Delhi, कोई Lucknow. किसी को भी आधी रात को फोन मारता था. बट इसके लिए जो भी आप डिस्काउंट दे सकते हैं दे दीजिए. बाकी सर्जरीज एवरी सिंगल डे, हार्ट सर्जरीज, नी ट्रांसप्लांट, ब्रेन ट्यूमर की सर्जरी सब जाने लगी. तो जब इतनी सर्जरीज होनी शुरू हुई तो वो लोग मल्टीप्लाई होने लगे. मेरे एक बड़े अच्छे दोस्त हैं, उनकी काफी एनजीओ से काफी सर्जरीज करवाते हैं. तो उन्होंने मुझे चीज बोली कि यार सोनू, तूने अपने खुद को ना शहद लगा लिया है. अब बहुत मैंने बोला कि परेशान नहीं. आई थिंक गॉड पीपल, और रास्ते खुलते जाएंगे. तभी प्रवीण अग्रवाल जी जैसे दोस्त मिलने शुरू हुए, और बहुत सारे लोग डिफरेंट स्टेट्स में मिलने शुरू हुए. हॉस्पिटल के डायरेक्टर्स, अपोलो में, फोर्टिस में, हर जगह पे. मैंने बोला कि यार मैं आपको देखो आधी रात को फोन करूंगा और आपको इनकी सर्जरीज करवानी है. मैं जानता नहीं कौन लोग हैं. मैं बस मेरी टीम कोऑर्डिनेट करती रहेगी. जो पैसे हुए आप मुझसे ले लेना. बस अगर किसी से 10 रुपए लेते हो, मेरे से 2 रुपए ले लेना, 3 ले लेना, ताकि मैं 5 लोगों की और सर्जरीज करवा पाऊँ. और विश्वास मानिए सर, everyone was on the toes कि यार तू टेंशन मत ले, हम जितनी जब बोलेगा सर्जरीज करेंगे, बट we'll do for you. तो सर मैंने एक प्रवीण जी से मैं बात करना शुरू किया. मैंने बोला कि यार ये तो हमने शुरू कर ही दिया है, और ये चलेगा कैसे, यू नो, I'll become busy as an actor एंड फिर उसके बाद शुरू कैसे होगी ये जर्नी। फिर मैंने ना एक से प्लेटफॉर्म बनाना शुरू किया जिसका नाम है, अभी भी इट्स इन द प्रोसेस, इन वीक 10 days आई विल मेक इट, उसका नाम है इलाज इंडिया। तो इलाज इंडिया वो प्लेटफॉर्म ऐसा था कि मैंने बोला कि जितने मेरे डॉक्टर्स हैं, प्रवीण जी के 5,000 डॉक्टर्स दोस्त होंगे और बाकी सब डॉक्टर्स के और दोस्त होंगे, कि यार इस प्लेटफॉर्म पर आ जाओ और एक सर्जरी मंथ में फ्री ऑफ कॉस्ट कीजिए, जो भी आप कर सकते हैं। हम लोग भेजेंगे कि राम लखन यूपी में गोरखपुर में रहता है, मधुबनी में रहता है, सर इसकी सर्जरी कर दीजिए जब भी आप फ्री हैं। तो आप बोलेंगे कि अच्छा ठीक है यार, वेडनेसडे को भेज दो, हम लोग भेज देंगे, सब कुछ करवा देंगे और वो सर्जरी हो जाएगी। तो धीरे धीरे हजारों डॉक्टर्स ने बोलना शुरू किया कि सोनू, जिस दिन वो इलाज इंडिया शुरू होगा हम लोग उसमें जुड़ेंगे और वो सब जितने पेशेंट्स हैं हिंदुस्तान में वो उस पे होंगे, डॉक्टर्स होंगे, एंड विल ट्राई टू मैप देम कि यार कहाँ पे हैं। क्योंकि मैंने इतने लोगों के साथ भेजा है, मुझे पता है कि बहुत सारे डॉक्टर्स करना चाहते हैं पर उनको पता नहीं है कि ये जेन्युइन है कि नहीं है, ये अफोर्ड कर सकता है या नहीं कर सकता, कि इसको कैसे हम लोग करें। सो मैं अपने बंदों को भेजता हूँ उनके गाँव में, यार जाकर देख के भैया राम लखन के पास कुछ है करने के लायक के जेन्युइनली जरूरतमंद है। बोलते हैं सर बहुत जरूरतमंद है, हम लोग सब उसका इलाज करते हैं। सर मैं करीबन अभी पिछले 2 महीने के अंदर ऑलमोस्ट 323 सर्जरीज करवा चुका हूँ इन ऑल डिफरेंट फील्ड्स। और मुझे एक सर्जरी की सबसे बड़ी तकलीफ जो आती थी वो था लिवर का। बोलते हैं यार लिवर यार लंबा प्रोसेस है, बहुत फॉलोअप होते हैं, बहुत खर्चे होते हैं, उसकी तरफ मत ध्यान दो। तो मैं शूट कर रहा था सर रामोजीराव फिल्म सिटी के अंदर, और शूट करते करते वहां पर एक फैमिली, एक हस्बैंड वाइफ, अपने छोटे सा बच्चा 6 साल का बच्चा था हर्षवर्धन, वो आया और उसको लेके मेरे शॉट के अंदर मेरे पैर में पड़ के रोने लगे। तो मैंने बोला क्या? तो उनकी एकदम उसके बेटे का जो पेट था बहुत फूला हुआ था। बोले कि यार ये 6 साल का बच्चा है और इसकी सर्जरी है हैदराबाद में हो रही है केयर हॉस्पिटल में और 18 लाख का खर्चा है उसके ऊपर, तो इसको बचा लीजिए सर। मैंने बोला कि आप टेंशन मत लीजिए, मैं कुछ करता हूँ, हम लोग निकालेंगे और करेंगे। फिर मैंने स्पोक टू few my friends in Apollo hospital, मैं सर इसकी सर्जरी करानी है, जो भी खर्चा होगा मैं करूंगा, बस खर्चा थोड़ा बचा दीजिए। तो डॉक्टर सेड डोंट वरी सोनू, वी वोंट चार्ज एनीथिंग, बेड की कॉस्ट लेके हम भी फ्री करेंगे, जो भी करेंगे उसके टेस्ट होने शुरू हुए। तो मैंने प्रवीण जी को बोला कि सर जितने आपके दोस्त हैं, आप मुझे आधी रात को 24/7, मेरा आज भी फोन है जो मुझे लगता है पूरे हिंदुस्तान के पास हो गया, मुझे आज भी रात को 2-2:30 बजे फोन करते हैं कि बिहार से फोन आता है, अरे सर क्या बात कर रहे हैं सर, हमारा बेटवा का बहुत तबीयत खराब, हम क्या करें हम लोग। तो मैंने बोलता हूँ कि बेटा कल उसको फ्लाइट से हम लोग पहुंचा के हम लोग बॉम्बे या हर जगह लेकर आते हैं। तो मुझे पता नहीं सर मैं कैसे करूंगा, मुझे पता नहीं कि कैसे मेरे साथ कितने लोग जुड़ेंगे, लेकिन मेरी आप सबसे, जो लोग भी मुझे सुन पा रहे हैं, मेरी आप सबसे एक रिक्वेस्ट है, आई लव टू स्पीक टू एवरीवन इंडिविजुअली, पर जिन लोगों तक भी मैसेज मेरा पहुंच रहा है, मेरी सिर्फ इतनी रिक्वेस्ट है, आप लोग कमाल का काम तो कर ही रहे हैं सर, पर बहुत सारे एनजीओ के थ्रू लोगों को पता नहीं है वहां तक कैसे पहुंचना है, वो लोग मुझ तक पहुंचना शुरू हुए, एक कनेक्शन जुड़ गया उनका, सब स्टेट्स का, जरूरतमंद लोगों का, जिनको कुछ भी नहीं पता कि सोनू जी आप हमारा करवा दीजिए। मैं प्रवीण जी के थ्रू आपको ट्रबल करूंगा, आपको तकलीफ दूंगा कि सर ये प्लीज आप मुझे गाइड कीजिए, हेल्प कीजिए कि कैसे एक काम हो सकता है, और अगर वो रास्ता हमें आगे तक ले जाएगा मंजिल, तो कुछ जिंदगी बच जाएंगी। तो उसी के लिए सर मैं आई वुड लाइक टू रिक्वेस्ट एवरीवन कि आपकी फैमिली तो स्ट्रांग है ही है, एक्सपीरियंस फैमिली है, मैं इसमें नया खिलाड़ी हूँ, मुझे उतना नहीं पता, बस ये सिर्फ एक पैशन है कि मैं हेल्प करना है सबको। आप भी मुझे इस फैमिली का हिस्सा बनाइए और बस आई विल बी ऑलवेज ऑन माय टोज टू गिव माय 100% and let's change the world sir and bring some happiness in the families that they are looking forward and बस इतना ही है सर, ज्यादा कुछ नहीं मैं जानता, बट आई थिंक आप लोगों के साथ सीख बहुत कुछ लूंगा मैं सर। जी सर।
थैंक यू मैम।
थैंक यू सो मच मिस्टर सूद। और ये वादा है कि टीपा फैमिली से जितना मदद हो सके हम लोग आपके साथ, आपको मदद करना चाहेंगे, आपके साथ काम करना चाहेंगे, और हम भी चाहते हैं कि ज़्यादा से ज़्यादा बच्चों को लिवर ट्रांसप्लांट मिले, अफोर्डेबल कॉस्ट में मिले, कॉस्ट इफेक्टिव हो और वो लोग एक अच्छी ज़िंदगी जी सके। And we are really thankful to you that you took out time for us and you extended your support towards TPAF. Really, thank you. Thank you so much.
Thank you so much. God bless you. Thank you so much.
Thank you. Okay, I would now request Mr. Pravin Agarwal to deliver the vote of thanks. Over to you, sir. Sir, can you please unmute yourself? You're on mute. Yes, sir.
Am I audible?
Yeah, yes, sir. Yes, sir.
Very good. So thank you once again, all of you. And once again, it was a pleasure to have all of you and all connected through this webinar and discuss new approaches and plans to conduct pediatric liver transplants in the times of COVID-19. I am hopeful that the discussions will help immensely to improvise the outcome of pediatric liver transplants amidst the global scare. Concluding our third edition of ALTC 2020, I would like to express sincerest thanks of our chief guest, Mr. Sonu Sood, who honored us with his presence today. I'm grateful to all the panelists, speakers, and delegates for taking off time from their busy schedule to participate in this webinar today, connecting with us across different time zones and share such gems of wisdom. I thank Mr. C.Y. Pal, Chairman, Infilum, and co-founder Jeet, for being with us this afternoon, and extend my thanks to the dignitaries of various Rotary clubs for attending this event and eventually making it a success. Last but not the least, I would like to thank the TPAF team and all the volunteers from Sterlite Group family who worked tirelessly to connect with all of you and make this event possible and make it even a success. TPAF looks forward to having you all and many more as its next conclave in 2021. Thank you.
That's good. For attending the ALTC 2020 and making it a success.